you start the recording? So Dr. Conteh will take us on ACLS and cardiac arrest and ACLS. So he will start when his slide is on. Dr. Conteh, we are ready. You have the floor. All right.
Okay, good evening, everyone. So today, we want to just discuss cardiac arrest and the core principles of ACLS. I think, like I mentioned the last time, ACLS is a practical program, but we'll try to just bring out the important points in this PowerPoint presentation. So let me go to slideshow. Good. All right. So today we'll try to discuss how to recognize cardiac arrest and then how to take care of a patient with cardiac arrest. So the appropriate characteristic of a high cost, talk about a high performance CPR team, and then just familiarize ourselves with the various algorithms of the American Heart Association ACLS program. We'll look mainly today, look at the tachy and bradyarrhythmias. Okay. So some basic definitions we should get clear. So cardiac arrest basically is just sudden cessation of cardiac activity so that the victim becomes unresponsive with no normal breathing and no sign of circulation. So it's important. They've modified this not to sound no breathing, because sometimes you can get patients with cardiac arrest and they have what they call agonal breathing, which is not normal. Okay, so you still, even though they have those gasps, you still classify them as cardiac arrest. So it's no normal breathing and no sign of circulation. So you can't palpate a pulse. Then you say the patient is in cardiac arrest and you follow the algorithm to manage such patients. This is the definition from the American Heart Association. From Bornwald's, it defines it as an abrupt cessation of cardiac mechanical function, leading to death in the absence of reversal by prompt intervention. Okay, so the AHA is a more practical definition, telling you exactly what to look for you to classify a patient as cardiac arrest. And Braunwald is going the more academic way. So it's just good to understand. They just mean one and the same thing. So sudden cardiac death is when you have sudden irreversible cessation of all biological function as a consequence of cardiac arrest, okay? Or simply put, death occurring as a result of cardiac arrest, right? So if you are not able to intervene at the stage of of cardiac arrest, then you proceed to sudden cardiac death, okay? So the sudden cardiac arrest, usually for practical purposes, we subclassify them into in-hospital cardiac arrest and out-of-hospital cardiac arrest. The out-of-hospital cardiac arrest is treated mainly under BLS, one person response, and what are the basic life support. So we'll just mention it in passing. We'll look mainly at the in-hospital cardiac arrest. Where we have
I think, Dr. Conteh, sorry, please, the village people have started. So the network.
Oh, my sound is fluctuating.
Yes, it's fluctuating. Oh.
Right. Okay. So the in-hospital one is what we look at mainly, where you have a team. Okay. An emergency response team. Okay, with training in ACLS to handle patients that go into cardiac arrest, and also to receive patients that has experienced an out of hospital cardiac arrest, and they have been rescued by either an emergency response or a bystander, and then brought to hospital and now handed over to the in-hospital emergency team. So brief about the epidemiology of cardiac arrest. So because of varying definition and, the short time that you have to manage the patient before they either resuscitated or they proceed to cardiac death, epidemiology data is a bit difficult to gather. So most times they are described in special populations. Okay. If you look at this table, looking at the incidence of sudden cardiac death in certain groups of population. Okay, so this graph gives you in percentage and then gives you absolute number. All right, so you see that patients who have heart failure, okay, they tend to have, in terms of percentage, a higher incidence of, sudden cardiac death. Okay, of course, people who have survived an arrest one, they are at higher risk of getting another. Okay, people who are prone to having arrhythmias, they are also at higher group, and of course, myocardial infarction, very important. And then generally, sudden cardiac deaths tend to occur more in men, okay, than women across all ages, as you can see. And this is data from the Framingham study, showing that men are more prone to having sudden cardiac death compared to women. So some of the etiologies of cardiac arrest. Okay. So ischemic heart disease is one of the major, etiological factors. So all the different types of, ischemic heart disease that we spoke about. So either from coronary artery, atherosclerotic coronary artery disease, embolism to the coronary artery, the minocardial, okay, coronary artery spasm. All right, all of them, anything that can cause ischemic heart disease, they tend to be responsible for higher prevalence of cardiac arrest. And then non-ischemic causes, many of them, cardiomyopathies, valvular heart disease, congenital heart disease, the arrhythmogenic diseases, okay, myocarditis, and the like. Then you also have non-structural causes of cardiac arrest. Okay, so the inherited arrhythmogenic disease, okay, the idiopathic VF, Brugada syndrome, non-QT, okay, the pre-excitation syndrome. And then you also have non-cardiac causes, systemic causes, pulmonary embolism, intracranial hemorrhage, people who drown, okay, they're going to arrest, certain overdose of certain drugs, especially illicit drugs. Okay, problem with the airway can cause cardiac arrest, and of course epilepsy is also associated with cardiac arrest. The major risk populations at risk for cardiac arrest. Okay, so as we've seen, generally men, the incidence for men are greater than women, as we saw in the previous slide. Okay, when it comes to race, The highest incidence is in blacks, okay? Followed by whites. So these are for studies in the US, and Hispanics have been shown to have the least, incidence of cardiac arrest, right? And as we mentioned, ischemic disease is a major contributor, okay? So even those with risk factors, among those with ischemic disease, you have it more common in men compared to women, okay? So if you have no coronary heart disease, the incidence is very low. Angina, it increases, and if they have suffered a myocardial infarction, it increases exponentially. So those are some of the major risk factors for cardiac arrest, in addition to other conditions that affect the heart. The reversible causes of cardiac arrest, this is very important, the H's and T's. We'll come across them again. So these are things that you can be able to treat in the emergency setting, okay? And these have been abbreviated into H's and T's to help us remember them. Because in that emergency setting, as you are evaluating the patient as to what will be the possible cause of the cardiac arrest, these are the differentials that should be going through your mind. And as you assess the patient, be able to exclude them. And if you confirm anyone, be able to treat emergently to help save the patient. So the H's are hyperkalemia, hypokalemia, hypoxia, acidosis, hypovolemia, and hypothermia. Okay, so the electrolyte problem, the potassium, oxygenation, okay, acid base problem, volume, and then temperature. All right, those are the H's. And the T, or thrombosis, so pulmonary embolism and coronary artery disease. Very common causes for cardiac arrest. Tension pneumothorax can also happen, tamponade, of course, and then toxin is very, very important, especially when assessing the patient, to be able to look for signs of toxic ingestion, like opioid toxicity. Okay. So, talking about the pathophysiology of cardiac arrest. So, mostly the final common pathway is a rhythm problem, okay? Either the heart goes into an abnormal rhythm, or you have an electrical activity that is not followed by a mechanical function. So this differentiation is very, very important, okay? So these two, ventricular fibrillation and pulseless ventricular tachycardia, are the main causes of cardiac arrest that you can treat via defibrillation. Okay, so these are your shockable rhythms. Okay, so when you see ventricular fibrillation, the ventricular tachycardia without a pulse, so the patient is unconscious, you palpate the pulse, you can't get a pulse, and you look at your monitor, you're seeing a VT, okay, or you see a VF, then those are arrhythmias that are amenable to shock, okay, defibrillation. And then you have the ones that are non-shockable, wherein you have to treat mainly with your chest compressions and other adjunctive medications, but shock cannot manage these ones, okay? So your pulseless electrical activity, wherein you have what looks like organized, electrical activity, but the patient is without a pulse and they're unconscious, okay? And then you can have the different forms of arrhythmia, the tachyarrhythmias, okay? Fibrillation and flutter can cause you to go into cardiac arrest. The bradyarrhythmias, so a complete heart block with a very, very slow rate, can actually cause the patient to go into cardiac arrest. And all this belongs to the non-shockable rhythm. Okay. You could have idioventricular rhythm. That is when the SA node fail, heavy node fail, and then the ventricle take over. Okay. But not being able to sustain the circulation. So you just see wide QRS complexes. Okay. And then you can get complete asystole. Okay. But when you have a systole, it is non-shockable. You can't deliver a shock to get the patient out of a systole. When the patient is in a systole, your first response should be compression, effective chest compressions, okay? And you administer inotropic agents to help restart the heart, or you don't shock an asystole. Shockable rhythm, VF, pulseless VT, okay? VF is always pulseless. You cannot get VF with a pulse. But there are certain times you get VT, you can still palpate a pulse. And the management is different, as we'll see as we go on later, when you have a VT with a pulse and when you have a pulseless VT. So the clinical presentation of patients with cardiac arrest, okay? So remember the definition. The patient is unconscious, no normal breathing, and no sign of circulation. So those are the three things when you are assessing the patient, they present, that you want to assess for, okay? So to assess for consciousness, you actually tap on the shoulder and you shout, you call the patient. You actually have to be vigorous to make sure that the patient is actually not responding. Tap on their shoulder and call out the patient. Okay, and if the patient is not responding, within 10 seconds, you should simultaneously palpate the carotid pulse to confirm whether, so you remember, you don't palpate the radial pulse. You palpate the carotid pulse to check for the circulation. And as you are palpating the carotid pulse, you look at the patient's chest for sign of breathing. Within 10 seconds, you should have made a decision whether you felt a pulse and whether the patient is breathing, okay? And if both of those are not happening, then you have to activate the emergency response, okay? By calling for help, especially within the hospital setting, you activate the code, all right? Good. So management of cardiac arrest. So as we said, the emphasis will be on in-hospital cardiac arrest. Okay. So key things are important for successful management of patients with cardiac arrest. The first thing, you need to have a system. Okay, the facility where you work. Okay, there should be a system. That's why in a lot of facilities it is mandatory, depending on the department where you work, to have BLS or ACLS training and be part of an emergency response team. Okay, you must have a team. And then we talk about the system of care and the chain of survival. So in settings where they have very robust healthcare systems, so from the emergency response service who meet the patient out of the hospital onto the in-hospital care, that chain of survival must be well established to ensure that the patients are properly managed. Okay, and as we said, immediate recognition of cardiac arrest is very, very important, because once the patient lost consciousness and the circulation is not active, it's just a matter of time before they go into sudden cardiac death. Okay, so immediate recognition is very important so that appropriate intervention can take place. And then for the in-hospital cardiac, you need to have a team, a multidisciplinary team, okay, that is assigned to be able to respond to such emergencies when a patient codes, okay, and with good team dynamics. So where team members know their role, they know their responsibilities, and they're able to communicate effectively. Okay, we'll talk about closed loop communication in emergency response, because the communication is very, very important. Okay, and be able to have a team lead to assign role and ensure that the roles and responsibilities are carried out effectively to be able to improve the outcome of the patient. So a team dynamic is very, very important. Okay, and preparedness of the emergency response should always be on high alert. Okay, and what they do in most hospital settings, you know, the emergency response team, they do simulations routinely, okay, probably on a quarterly basis or half-yearly basis, okay, so that even when they do not get cases frequently, but they do routine simulations to just keep them on their toes, so that, you know, the response to an emergency become a reflex response, okay? It becomes actually a spinal sense rather than something that you have to think about. Once the patient comes, they present, you know exactly, it comes like a reflex. You know exactly what to do, what next to, what to give. Okay, so preparedness is very important, and that comes about by continuous training and simulation. Then high quality CPR. Then now this is where the emphasis is, because it has been shown that the survival of patients after cardiac arrest largely depend on the quality of CPR they receive to be able to maintain the circulation and try to revive the patient. That is very important.
Hello, I can't hear you. I don't know if it's just my side.
Oh, okay. Is it better? Sorry. Hello?
It's better. It's better now, but we lost you when you started the high quality CPR statement.
Okay, so the evidence nowadays, when they look at data, places where they've been handling cardiac arrest, that the main factor affecting survival is the quality of the CPR. Okay, the chest compressions, how effective the chest compressions are, because those chest compressions are what maintain the circulation, maintain brain perfusion and cardiac perfusion until the heart is able to, you know, restart and take over its function. So it is the main driver of success in terms of cardiac arrest, okay? And we'll talk about what are the components of an effective CPR, okay? And if the patient has a shockable rhythm, early defibrillation, okay? Because you have to treat effectively. If the rhythm is shockable, you don't have to go on continuously compressing. You have to deliver the shock to defibrillate the patient, okay? That improves success. And if it is a rhythm that is non-shockable, then you don't have to shock. But once you get a shockable rhythm, the shock has to be delivered as soon as possible. Okay, then of course the post-cardiac arrest care and recovery, also very important to ensure that the patient makes a full recovery from the episode. All right, so this one just shows the chain of survival for in-hospital and out-of-hospital cardiac arrest, okay? So when a cardiac arrest happens out of hospital, activation of the emergency system is very important. So that should be done very quickly by a bystander, okay?
I think we are losing you. We are losing you, sir. I don't know if you can a little bit adjust your network, your position. We are losing you. Sorry.
Okay. Is it better now?
Yeah, it's better. It's better.
Yeah. So the first thing, once you recognize,
Hello. The network.
yes.
This network, where they have to fight it. When important things are about to be spoken, the network can misbehave. All
Okay,
these village network.
Just give me
It's better, but in between, it will revert back to the village mode. That's the challenge. But let's give it a shot and see. Let's try and see.
Yes, how about now? Better?
Excellent, excellent, yeah.
Okay, fine. So the top panel is showing the pain of survival for out of hospital cardiac arrest. Okay, so once cardiac arrest is recognized, the first thing in the out of hospital setting is to call for help. Okay, where there is a good emergency service, make the call, the emergency service. Okay, and basically shout for help so that people come. And once you've called for help, the next thing is to start chest compression immediately. Immediately, high quality CPR. Okay, because as we said, this is what maintains the circulation as the patient is lying unconscious. Okay, and then if the rhythm is shockable, immediate defibrillation. Okay, in advanced countries now, they have the automated defibrillator, which anybody can use. Okay, you switch it on, it gives you commands what to do next and how to deliver a shock. Okay, so for people who are trained in BLS, okay, they should be able to handle the automated defibrillator. So once they start compressions, if the defibrillator is around, they ask for someone to bring the defibrillator and they connect it. Okay, the automated defibrillator will analyze the rhythm by itself and then tell you that a shockable rhythm has been recognized. Okay, and when it wants to deliver the shock, it will tell you to clear the patient, and then you just need to activate the button to deliver the shock. So it makes life very easy. Okay, and then once you're able to maintain, sustain the patient, okay, once help arrives, the patient has to be transferred to the advanced resuscitation team, okay, the in-hospital team, okay, and the in-hospital team should take over the management and then provide the post-cardiac arrest care and help the patient to recover fully, okay. So similar steps happen again if the cardiac arrest happens in hospital, okay. So one of the important things within the hospital is recognition of a cardiac arrest, okay. So in the various units, they should be able to recognize cardiac arrest immediately. But beyond that, if you're able to prevent cardiac arrest, should see a patient that is not doing well, intervene early before they go into arrest. Because when they go into arrest, the prognosis gets worse. Okay, so apart from early recognition, preventive, preventive interventions are also very, very important. Okay, so in the emergency department, you're getting a patient coming with saturation 85. Okay, you put on a non-rebreather mask, the saturation is still going down to 70. You know that this is you need an advanced CR to ventilate. Don't wait until the patient goes into cardiac arrest. You take action to prevent the cardiac arrest. It's very important in the in-hospital setting. Okay, so once you recognize, you have to activate the emergency system. Okay, so a lot of hospitals, they have certain alarms that are set off, okay? And members of the emergency team will converge on where the alarm goes off to be able to resuscitate that patient, okay? Some other places, they have beepers. So once the beeper goes off, all the members of the team converge to that particular point and be able to resuscitate the patient, okay? So activating the emergency response is very important. So once you activate the response, the person who recognizes must start CPR immediately as other members of the team join, okay? So once other members of the team join, connect the patient to the monitor, okay? So in the hospital setting, we will be using a manual defibrillator, not automated defibrillator. Because in the hospital setting, you expect that the personnel there are well-trained in ACLS and know how to operate a manual defibrillator, okay? So we put a defibrillator, and if you get a shockable rhythm, you must not waste time. So if the rhythm is shockable, the treatment for that rhythm is not chest compression, it's to deliver the shock. Deliver the shock. For a shockable rhythm, the shock is the most important. You have to deliver it, okay? And then your compressions and the other medications that you use, they are adjunctive treatment. But the primary treatment of a shockable rhythm is to deliver that shock. Once you recognize it, shock it, okay? And then, so once you're able to defibrillate, the next thing is the post-cardiac arrest care, which is basically the same as the out of hospital and then recovery. So those are the chain of survival. And all this chain must work effectively for the good prognosis of the patient, okay? Any break in the chain can actually cause the patient life, right? So you need a very high performance team to ensure that you get successful resuscitations. So the multidisciplinary team, what are the main things that the team must be efficient with, high performance team? One is the timing, okay? It must be very, very time conscious, okay? So you must not waste time to start compressions once you recognize a cardiac arrest, okay? Because that is what is going to maintain the circulation and keep vital organs perfused. So you must not waste time. First compression must be very fast. As soon as you recognize, you start compression, okay? And then the time, if you get a stable rhythm, you must be fast to shock the patient, okay? Shockable rhythm must be, shock immediately, okay? Your chest compression fraction, okay? Your chest compression fraction. So your chest compression fraction is the percentage of time you spend compressing the chest right through the period of resuscitation, okay? Right through the period of resuscitation. So for instance, if you resuscitate a patient for 10 minutes, okay, out of that 10 minutes, 8 minutes must be spent compressing the chest. That is what you should aim for, okay? So you have to ensure that there are minimal interruptions to chest compression, okay? We'll talk about the things that you can, practical things you can do that to minimize, the interruptions in chest compression, because that is very important. So you aim to achieve 80% chest compression fraction, right? And then minimize pre-shock pause, okay? Before you shock, so that the person who is compressing does not wait a long time. So the person who will be handling the defibrillator must make sure that the charged defibrillator is charged before they ask the team to clear, okay? You don't just take the defibrillator and ask everybody to clear, and that's the time you begin to charge the defibrillator. You lose compression time and you compromise perfusion. So you make sure, say, before you deliver a shock, you minimize the waiting time, okay? The sooner you ask people to clear, the next thing is to deliver the shock, right? And then, of course, early emergency service response time, very important. The coordination is also very, very important. So team dynamics, you must have a team leader, and then members must know their role. They must be able to work together, okay, and be proficient. And importantly is the quality of the CPR, so your chest compression, okay? There must be quality in rate, okay? So between 100 to 120 per minute, okay? That's the standard rate of compression. And then the depth, about 5 to 6 centimeters when you press on the chest, okay? To ensure that when you press, blood is ejected from the heart, okay? And once you compress, you must allow time for recoil. Because if you don't allow the chest to recoil, feeling will not occur. And if the heart does not feel, it will not eject. Okay, so those are very important for high quality. The rate must be appropriate, the depth must be appropriate, and you must allow time for recoil of the chest. Okay, and as we said, you minimize interruptions. Okay, so when you are doing rhythm check, if you have to give medication, if you want to do a quick ultrasound, if you want to do something, take a sample, you do it within that time that you are doing your rhythm and pulse check. And that should not take more than 10 seconds. Compression should start again. Okay, so you want to minimize interruptions and aim to achieve the 80% compression fraction. Avoid excessive ventilation. Okay, so the standard is when you are resuscitating the patient, 2 breaths, rescue breath after 30 compressions. Okay, 2 breaths after 30 compression. And when you deliver the breath, you must make sure that it lasts for 1 second. Okay, and another 1 second. So after 30 compressions, you give 2 rescue breaths, so you don't over. They will look at how to handle the airway to make sure that you're seeing chest rise and you are not inflating the stomach, which will further embarrass respiration. Okay, and then the use of feedback device, very important. Okay, so this feedback device have been able to help, CPR team actually objectively monitor the effectiveness of the CPR. Okay, and it is the use of these feedback devices that they've been able to get concrete data that the chest compressions are very key to survival of the patient. Okay, and in order to make your team effective, using feedback device can actually help. Okay, and then finally, the administration of the team. So leadership is very important. Okay, your measurement, you must always have a timekeeper. Okay, because when we go through the algorithm, you'll see, because a lot of the interventions you take, they need to be timed. What to do next at this time, what to do next. Okay, so you must have someone who is a timekeeper, okay, and who communicates very well, so that whatever action you take, it is communicated in a closed loop communication, and you can cross-reference with the timekeeper what stage of the resuscitation you are. Okay, and the timekeeper is able to give you feedback, and you're able to find yourself, because especially being the team leader, have to coordinate several things. Sometimes you might lose track, but the timekeeper should be there to keep track of everything that is being done, and you can cross-reference with him, saying how many doses of norepinephrine are we given? Okay, what this is what number of shock are we at now? Okay, you're able to, so that you're able to know the next steps to take. So it's very important to have someone who measures the time, right? And then continuous quality improvement is very important. So after a successful resuscitation, you come and re-evaluate and see what are the things that were done well, what are the lapses, and see how you improve. And if a CPR does not go well, you also re-evaluate, try to find out why it did not go well, and do continuous quality improvement, okay? And then you must be able to make sure that you have a manageable number of team members, okay? Because at times when you have too many, then it becomes chaotic. So you must have an appropriate number of team members. So between 5 to 6 is adequate for the team members of a good CPR team. All right. So this schematic shows you the role and position of a 6-member high-performance team. Okay, 6-member high-performance. So with a patient lying supine that you are resuscitating like this, okay, these positions are recommended. Okay, so the leader of the team, okay, stand back a little bit, and then so that he can see what everybody is doing and coordinate everything that is being done. Okay, so with the algorithm and the steps to take, and he gives the instruction. Okay, every action goes through him. Okay, and he determines what should be done next. Okay, the next one is a timekeeper or the code recorder that keeps the time and take records of every intervention that is being done and at what time. Okay, and we're able to give the leader feedback as and when necessary. All right. So the chest compressor, okay, so usually stand on the right of the patient, okay, directly over the patient on the side of the bed, okay, and you must make sure that when the chest compressor is standing over the patient, the elbows are fully extended, okay. If the bed is too high for you to have your elbows fully extended, you can use a stool so that you're able to deliver effective compressions, okay? And the person who is at the chest compression, they should be able to switch every 2 minutes or when the person is tired, okay? Must be able to switch, right? And you try to switch during the pulse check, okay, so that you don't switch. You have to stop the compressions to switch, and then again you have to stop to check pulse. So once you are checking pulse, that's the time you switch. Okay, like I mentioned earlier, if you want to administer medication, you administer so that, because remember you have a target of chest compression fraction. So you want to, so it's very important that because you'll be checking the rhythm and pulse every 2 minutes, better to switch the compressors every 2 minutes. Okay. Then the person on the left side is the one that manages the defibrillator. Okay. And this person that manages the defibrillator can alternate roles with the chest compressor. Okay. Because the defibrillator, you are basically resting and just waiting to deliver a shock. So you can alternate roles with this person when they are tired, right? And then the person that manages the airway stand at the head of the bed, okay? So we'll see how one person manages the airway, and then if you have 2 people managing the airway, you can make it more effective how you go about that, okay? And then the last person is the person who gives medication, who is responsible for IV access, ensuring that IV access is established and maintained, and any medication that is needed to be given is given immediately, okay? In the acute setting, when you are resuscitating a patient, if you cannot get an IV access, you can actually administer the medications intraosseously, okay? You can actually administer it intraosseously. Okay, the pediatricians make use of that very often. A lot of the time in adults, you are able to find a vein, even if it's a central line. Or in pediatrics, you might have to go through the interosseous. And if at all in adults you cannot get, then you can administer through the interosseous. Okay. So the person who is handling the airway provides ventilation through a bag mask. Okay. And because it is in the in-hospital setting, it should be connected to oxygen to deliver a high level of oxygen to the patient to ensure good saturation. Okay. Good. Now, so let's talk about airway management. Okay. So when a person go into cardiac arrest and they become unconscious, as you see in this schematic, okay, once they lose consciousness, the pharyngeal muscles and the tongue lose their tone. And when they lose their tone, they fall back. And when they fall back, they cause compression of the airway, especially when the patient is lying supine. Okay, so and this can actually hamper respiration when the patient is unconscious. Okay, so if the patient is breathing spontaneously, okay, all you need to do is one of these two maneuvers. Okay, you can do a head tilt and a chin lift. So it tilts the head backward, and then it's like you are pushing the chin forward. So when you push the chin forward, you see that it opens up the airway, and the patient can be able to breathe. Okay. An alternative to this head tilt and chin lift is the jaw thrust. Okay, wherein you hold the side of the head, okay, with the tips of your fingers at the mandible, and you actually push the mandible forward. And once you do that, it removes the tongue away from falling back into the airway. Okay, so for a patient who is breathing spontaneously, okay, by just doing this, you can allow them to be able to take in breaths, breathe in and breathe out, and maintain their airway. Okay, or mostly in the in-hospital setting, we have to use mask. Okay, nowadays, because of infection risk, mouth-to-mouth resuscitation is not advised. Okay, it's not advised. So now there are what are called pocket mask. Okay, this pocket mask has a valve so that when you blow into it, when the patient breathes out, nothing comes back to you. Okay, and you are able to apply it and seals over the mouth and the nose of the patient. You're able to give the patient rescue breath doing this. So first responders actually expected to be working with these in their pockets. Okay, and members of the emergency response team within the hospital should also have this in their pocket. So before the valve mask is brought in, you can start giving rescue breath with the pocket mask. Okay. So this schematic shows you the bag valve mask. Okay, so you have a mask plus a bag for ventilation. And then you have the connection to the oxygen inlet. Okay, so once you connect this, the oxygen fills the reservoir, and then you ventilate with this. Okay, you squeeze in and out and ventilate. Okay, so when you are ventilating the patient, you don't want to overventilate. You just want to give tidal volumes. Okay, and you don't need to squeeze the whole balloon down. You just squeeze it halfway and you release slowly and gently. Okay, so when you are delivering the breath, it has to be delivered over 1 second. Okay, it's not something you have to do very vigorously. All right, so in cardiac arrest, how do you manage the airway? Okay, so if it is a single person managing the airway, you do what is called the EC clamp technique to be able to stabilize the mask and fit the mask airtight around the nose and the mouth while you bag with the bag valve mask. Okay, so the EC technique, all right, with your left hand, okay, you hold the mask with your index finger and the thumb, that is the C, okay, and you use the rest of your fingers to grab the mandible, and you do a jaw thrust at the same time so that you clear the airway as you bag the patient. Okay, so this is what you do in the emergent setting. The patients are just coded and you've been summoned the first person who was there is on the chest. So as soon as you arrive with the bag mask, go to the patient's head, okay? Do your EC clamp, so your index and thumb around the mask, so fit it, hold it tightly against the nose. So you have to cover the mouth and the nose, okay? And then the rest of the 3 fingers form an E to grab the mandible and thrust it forward so that the airway is open. And then you bag with the right hand, okay? So for more efficient delivery of breath, okay, you can get 2 people managing the airway, okay? 1 person bagging, and then the other person ensuring that the mask is well fitted on the patient, okay? So you do, the person who is holding the mask, do a double EC clamp, okay? So the same C to hold the mask with the index finger and the thumb, but this time you do it with both hands on either side, okay? And then the E again with the rest of the fingers, grabbing on the mandible and thrusting it forward to open the airway, okay? So that's the double EC clamp technique for airway. So as you continue the resuscitation, you can move to better airway management, okay? Other adjuncts that you can use to help you stabilize the airway and ensure that you are breathing. So one of the first and simple, equipment that you can use to maintain the airway is the oropharyngeal airway, okay? Oropharyngeal airway. So you have to make sure that the oropharyngeal airway is of the appropriate size. Otherwise, you will defeat its purpose. It won't be able to ensure that air is breathed in and out into the patient, or air is pumped in and out into the patient, okay? Because when you put the mask, it must go right behind the pharynx and then direct the air into the trachea, okay? So to size the oropharyngeal mask, you put it to the angle of the mouth, okay? And then the tip must get onto the angle of the mandible, okay? If it does not reach the angle of the mandible, then it is small. If it goes past the angle of the mandible, it is too big, okay? Either way, it will not achieve the purpose. So you have to make sure you get a size that fits, okay? Then apart from the oropharyngeal, you have the nasopharyngeal airway, okay? The nasopharyngeal airway, all right? Even though it might sound uncomfortable passing the nasopharyngeal airway, people who are semi-conscious better tolerate even the nasopharyngeal airway, okay? It is soft, and once you put it, it goes behind and you're able to bag the patient, okay? Yeah. So the nasopharyngeal airway, you size it, should extend from the tip of the nose, and then the tip of the nasopharyngeal airway should get to the lobe of the air. Okay, so the oropharyngeal is to the angle of the mandible, from the angle of the mouth to the angle of the mandible. For the nasopharyngeal, from the tip of the nose to the earlobe. Okay, and then that is the size that fits, that will deliver the air behind the oropharynx into the trachea. Good. What about the advanced airway? Okay, advanced airway. So the first one is the laryngeal mask airway. Okay, the laryngeal mask airway. So this one, it is fitted to just sit on top of the larynx. Okay, and when it's inflated, it seals off the oropharynx from the larynx so that secretions don't get into the airway. And also, when you bag on this, it is delivered straight into the trachea. Okay, so this one also has various sizes. Okay, and they're usually sized based on the weight of the patient. Okay, and then you put it, it fits, and then you inflate it, so it stays in the pharynx. Okay. Because of the way it is made, okay, it can easily be dislodged, okay, especially if the patient having lots of secretion and they are beginning to gain consciousness, okay, wanting to remove whatever is in their throat. It is not a secured airway, okay. So the best of the advanced airway is the ET tube, wherein you actually intubate the trachea and inflate the balloon so that secretions do not go in, okay. And this ensures that you have a safe airway and you can even transition the patient into ventilation with this one, okay. So now let's talk about the CPR, the high quality CPR, okay. So as you can see from the schematic, okay, a lot of the time, people are tempted to compress over the left chest wall because the heart is on the left. They think you deliver better compression. When you look at how the chest wall is constructed and how the chest wall works in terms of respiration, okay? Remember from respiratory physiology, the bucket handle and the pump handle movement. That when you deliver compressions to the sternum, you achieve better movement better compression of the thoracic cage compared to when you deliver those compressions on the ribs, okay? And when you deliver them on the ribs, you're at a high risk of causing rib fracture. And when you are delivering them on the sternum, because the sternum, the joints, the sternocostal joints, those costochondral joints are adapted to be able to accommodate compressions of the sternum, okay? So you should compress at the center of the chest, just above the Ziphy sternum, okay? That's where you compress. You press deeply. So your shoulder, your elbows must be straight above the patient. You should not flex at the elbow, okay? So when you are moving, when you are compressing, you move your frame, you flex. That is your fulcrum. You are moving about 15 to 20 degrees, okay, around your hip, right? And you press. So when you press, you want to make a movement of about 5 to 6 centimeters, okay? In inches, it's about 1.5 to 2 inches, all right? And so that's how you deliver good compressions, okay? If the patient is on a hospital bed, okay, it is good to use a backboard so that you have a strong surface behind the patient so that the compression is not absorbed by a very soft bed, okay? There are special resuscitation boards that are also available for the in-hospital setting. If you don't have those ones, you can just use any board, any hard surface behind the patient, okay? And sometimes if you don't have the hard surface, you are better to remove the patient from the bed and put the patient on the floor. Because if the bed is soft, especially the ones that have those springs underneath, your compressions, you won't be delivering good compressions, okay? So the back of the patient must be hard to ensure that the compressions are good, okay? So as we said, the compression rate, the high quality compression, the rate must be between 100 to 120 per minute, okay? And a depth of about 5 centimeters or 2 inches, okay? And then you must allow full recoil. Once the heart ejects, it has to fill. If you do not allow the recoil, the heart will not fill. So you have to allow full recoil, okay? And then you must minimize interruptions to less than 10 seconds, okay? So every 2 minutes, you allow only 10 seconds interruption to check the pulse and rhythm. And whilst you are doing that, you can change compressors, okay? If you want to take sample, okay, you want to administer medication, you can do that quickly within that interval, and compressions continue immediately after, okay? So you give rescue breaths, okay, over 1 second, and you avoid over inflation, okay, or over ventilation, okay? So you give the breath, 2 breaths after 30 compressions, all right? And then as we said, you can switch compressors every minute so that you take advantage of time when they're checking the pulse and the rhythm. Okay. So this is the feedback device. Okay. So this is an example of a feedback device. So you actually put it on the chest as you compress, and it will give you a green light. A green light will come if you are doing good compression. The compression is not. Hello? Hello?
We have lost you.
Oh, at what
Hello,
point?
can you hear?
I can get you.
Just an interruption now. You can go ahead. It's fine.
Oh,
You were
okay.
at the feedback device. The feedback device.
Yes.
We're talking about the feedback.
Yeah. So it's a feedback device to actually give you real-time feedback of how well you are compressing the chest. Okay? Because as we said, compression is what maintains the circulation as you try to resuscitate the patient. So it has to be prioritized. Okay. So this is an example of a feedback device. So you put it underneath and between the patient chest and your hand as you compress. You actually compress on it and push on the chest. Okay. So when you're having good compression, you see green light coming up, green light coming up. Okay. If the compression is not of adequate depth, is a little below, they become yellow. If they are very, very shallow, it's red. Okay. And it will give an alarm. Okay. So you have to make sure you are getting green light all the time when you are compressing. Okay. That is very important. And this schematic shows you the importance of not interrupting the compressions. So when you are compressing, okay, when you start compressing, you have to compress to about 8 to 10 times before you begin to achieve coronary perfusions. And sorry, coronary perfusion. Okay, this is your coronary perfusion pressure. So after you've compressed about 8 to 10 times, that's the time blood begins to flow. And then when you maintain it, you get very good flow. So once you interrupt, everything goes down. And then you have to start the cycle again. It has to pick up again. Okay, like you are driving a manual car. Okay, so once you stop, you have to start from gear 1 again, and then you pick up before you reach and start maintaining your speed. Right? So because of these interruptions in coronary perfusion, that is why for you to have effective chest compression, you must try to minimize interruption to the barest minimum. And once you're able to do that, achieving a chest compression fraction of above 80, then you're doing very effective CPR. Okay. So let's talk a bit about the defibrillator. Right. So there are different designs, different manufacturers. Okay. So in your facility, you must make sure that you familiarize yourself with the settings and the workings of the defibrillator. Okay. Because it's not when you have an emergency, that's the time you begin to check where this button is, where this function is, how to change the mode in the defibrillator and all. Okay. So it's always good that you familiarize yourself with the type of defibrillators you are. Okay. So generally, the modern manual defibrillators, okay, they can discharge both synchronized and unsynchronized shocks. Very, very important because defibrillation is different from cardioversion. Okay, if you go and defibrillate where you are supposed to cardiovert, it might actually cause more harm than good. Okay, so when you are defibrillating, you use unsynchronized discharge. Okay, because in those cases where you are defibrillating, the person does not have an organized, cardiac activity. So either you have a VFib or a pulseless VT. So you can discharge the shock at any point in the rhythm, and then it will help to switch the patient into a more organized rhythm. Okay, but when the patient has an organized rhythm, okay, for instance, you have an atrial fibrillation or you have a VT with a pulse, okay, you do not do defibrillation, okay, you do cardioversion, synchronized cardioversion, right? So with synchronized cardioversion, you have to turn the synchronized button on whilst the monitor of the defibrillator is on the patient. You turn the synchronized button on. So the machine has a sensor that will determine the peak of the QRS complex or the peak of the R waves, okay? And the synchronized cardioversion shock is delivered at the peak of the QRS when the heart is being depolarized, okay? Because you don't want to deliver a shock in an organized depolarizing heart when the heart is in repolarization, okay? After the QRS going to the S and T wave, ST segment and T wave. Because if you do that, you can actually trigger arrhythmia. You can actually trigger the patient going into VFib, okay? So it's very, very important that you don't defibrillate when you are supposed to cardiovert, right? So when you synchronize, it will deliver the shock at the peak of the QRS, okay? So, and when you do this synchronization to avoid you delivering a shock during repolarization, and also when you are doing synchronized cardioversion, you deliver a lower energy to the patient, okay, which also lower the risk of getting the patient into VFib, all right? And then another important thing about the defibrillators, most of them that come now, they are manufactured with a pacing mode to the defibrillator, okay? You have a pacing mode, and you use the pacing mode for patients who go into bradycardic cardiac arrest, or they have a bradycardia with hemodynamic compromise, okay? So you should know that the pacing mode is also there. And when you want to pace, you don't use these puddles, okay? You use the specialized pacing pads that are adhesive, and you stick them onto the patient, as you will see later when we talk about the bradycardia, okay? Use the puddles to defibrillate or cardiovert. But if you want to pace, you use the pads, all right? Good. So let's just go over the steps for if you're a single responder and you are doing, you're to do a CPR for a patient, okay? Say you are a doctor, and then you are in a flight, and then the person just arrested. And when the flight attendant asks, do we have any medic on board? That's when you know that not everybody wants to identify themselves as medics. Except they check the manifest and they say, seat number 5 is a medic, please come to our rescue. Right? But when you are a single person, these are the steps you have to go through, okay? So the first thing, when you get to the scene, yes, yeah.
In Nigeria, we do gastric lavage, or we force hemesis in Nigeria. as though you are trying to decontaminate. You just remember one of them. All right, sorry for the interruption. Just light. Thank you.
Yes.
Thank you.
So the first thing you do once you respond, you have to verify that the scene is safe. It's very important for you and for the patient. Okay. Make sure that there are no sharps lying around. Okay. There are no contaminants that will put you or the patient at risk. So you check the safety of the scene. Okay. Once you are sure that the scene is safe, then you go into action. You check for responsiveness. Tap the patient on the shoulders vigorously and call out. Okay, hello, hello, are you okay? Tap the patient and shout to ensure, to make sure whether they are responsive or not. Okay, if they are not responsive, you call for help. Okay, so that someone from maybe if it's in a flight, the flight attendant will go and get the crash cart, their first aid kit, and bring it to help him. Okay, if it's in a crowded shopping mall, a lot of these shopping mall, crowded places, they have first aid kits. Someone can run to get the first aid kit, a security personnel. They are also usually trained in CPR, so they can go run and get the kit for you. Okay, and once you shout for help, then you've activated the emergency response. Okay, so if in places where you have organized system, you can call the emergency response 911 or whatever you have, what have you. Okay, and at that time, once you've activated the emergency response, if it is a place where they have automated electrical defibrillator, then you can ask for it to be brought close to you as you start compressions. You start once you ask for this, you've checked the patient is not responsive, you've called for all of this, you need to confirm a diagnosis of cardiac arrest. Remember the 3 steps. So patient is not responsive, then you have to look for breathing and check the pulse. Okay, and you have to do that within 10 seconds. So once you assess, okay, if there is no breathing, okay, and no pulse, or the patient is only having what I call agonal breathing or gas, then you have to start CPR. Okay, you need to start CPR immediately. So you do your compressions, at least 100 to 120 per minute, okay? And then, so if you have your bag mask in your pocket, you compress and then you give 2 rescue breaths after 30 compressions, okay? So you have to do that you alone until you get someone to help you. Then the person can be giving the breaths whilst you continue the compressions. But if you are alone, you have to do 30 compressions and then you give rescue breaths, okay? And then as soon as the AED is available, you make use of it. Now, coming back to this point, if the patient is breathing normally and you feel a pulse, then you need to monitor, okay? The patient is not in cardiac arrest, all right? If the patient is not breathing, but you feel a pulse, okay? They are not breathing, they are unconscious, but you feel a pulse, it is still not cardiac arrest, okay? So this is just an unconscious patient, and what you need to do are rescue breaths. You provide rescue breaths, okay? So in providing rescue breath, you do 1 breath every 6 seconds, okay? Or in other words, 10 breaths per minute, okay? So every 6 seconds, you do 1 breath, all right? And then you continue to check the pulse every 2 minutes to make sure that the pulse is there, and you continue to give your rescue breath, okay? And then as you do that, you can try to decipher what has caused the unconsciousness. Does it look like someone will overdose? Okay. Does it look like is the patient cold? Is it hypothermia that is responsible for it? Okay. And based on what you find, you go with that particular protocol. All right. So remember this: if they are breathing normally, the pulse is felt, then you just need to monitor them as an unconscious patient until help comes. If they are having pulse, but they are not breathing well, they are still unconscious patients, you have to monitor them. But in addition to just monitoring, you have to be giving rescue breath. So when there is no pulse and there is no breathing, that's the time they fulfill your criteria for cardiac arrest, and you have to start CPR immediately. All right. So once you started your CPR, and immediately an automated defibrillator is available. You have to connect it straight away. Connect it. The person who comes with it, if the person has an idea, the person can connect it straight away, okay, whilst you continue your compression. If the person does not know how to do it, then you can instruct the person to take over compressions, and then you apply the AED, okay? Once you apply the AED, then the AED will take over. It will analyze the rhythm, okay? And if the rhythm is shockable, it will tell you it's a shockable rhythm, okay? After it has analyzed the rhythm, it will tell you to clear the patient. Once you clear the patient, and then you can press the button to deliver the shock, okay? And then immediately, anytime, as soon as you deliver a shock, the next movement is to continue compressions, okay? You don't deliver a shock and then go and start checking for pulse, okay? Or start looking at the rhythm. As soon as you deliver a shock, compressions continue, okay? Once you are doing the compression, if it is an AED, the AED will go ahead and be checking the rhythm. And if it needs you to stop to check the rhythm, it will do that after 2 minutes, so that if the shock has been successful, the rhythm would have stabilized. And then it will tell you to stop compressions for rhythm check. Then the AED will check the rhythm, okay? If it is a normal rhythm, then it will tell you a pulse is found. And then you check the pulse. If the pulse is on, then you have, if you feel a pulse, then you've been able to achieve ROSC, return of spontaneous circulation. But if there is no pulse, then you have to continue the compressions. Once you feel no pulse, continue compressions. And if it is the AED will analyze the rhythm again, okay, and tell you to clear the patients to deliver another shock, which will be about approximately 2 minutes after the previous one, okay? So after a shock is delivered, no waste of time, you go into compression mode, okay? When you are using the manual defibrillator, we'll talk about that. This one is for the AED, okay? So in case the machine read and it's a non-shockable rhythm, okay? Once the rhythm has been analyzed, you start compression straight away. You continue compressions, okay? And then you continue repeating the cycle. You compress, and then the machine will analyze the pulse, okay? If there is no pulse, you don't feel a pulse. If the machine does not analyze the shockable rhythm and you do not feel a pulse, you continue compression, okay? And the rhythm will be analyzed every 2 minutes, until ACLS provider takes over the victim. So either an emergency team arrive at the scene, or a team from a hospital nearby arrive at the scene and take over the ACLS, which is what we're going to look at next. All right, so this is the expanded system approach. So how the handing over takes place from the BLS to the ACLS, okay? So this one just summarizes what we've been talking about, okay? So you see the patient, your initial impression, the patient is unconscious, okay? Check responsiveness, activate the emergency, get the defibrillator, check breathing and pulse. No breathing, no pulse, you start compression straight away, okay? And then the cycle goes on. Every 2 minutes, if you connect the defibrillator will tell you when they are checking rhythm. If it is shockable, it will tell you to clear, it delivers a shock, and then immediately after the shock, continue compressions, okay? If it is not a shockable rhythm, it will tell you to continue compressions, okay? And every 2 minutes, the pulse will, so that cycle will continue. Okay, that cycle will continue until the ACLS, the Advanced Cardiovascular Life Support Team, arrive. Okay, so when they arrive, the advanced team, they will do a primary survey, okay, even as compression. So one of the team member who is responsible for compression will take over the compression, and the team lead will quickly do a primary survey, assess that the airway is patient, the patient is getting good airway. Okay, if probably the jaw was not tilted enough, it will tilt it or put an oropharyngeal tube. They now have a bag and a mask, okay, handy that they've come, ensure that the airway and breathing are taken care of. And they will check the circulation as well. Check if we're still getting any pulse. If no pulse is happening, ensure that compressions are going on. And just quickly assess the patient for any disability. Is it a patient that has suffered a stroke? Or is it a patient that is having a heart attack? Okay, assess what disability has happened to the patient, and then ensure that the patient is adequately exposed, okay, so that they can get access to give IV medication, okay, access to take samples, and also proper exposure of the patient. And then they continue now with the ACLS protocol, which we are going to talk about, okay? So same thing here, if the time that you assess a pulse was present, all you have to do is rescue breath until the advanced team come and take over, okay? If the patient was conscious, when you call, they responded, okay? You still just monitor them because they have collapsed. You monitor them until the advanced team come to take over, you know, to do post-arrest care or post-collapse care. Good. Now, so managing a cardiac arrest team with high performance team cardiac arrest algorithm. Okay, so according to the 2021, we see the members of the team, the high performance team, okay, the chest compressor, the one on the airway, the man on the defibrillator, okay. This is the team lead giving all the instructions, okay, and then this one here would be accessing for giving medications, okay? This one just a snapshot of how the entire team position themselves and ensure that everything is coordinated when they come to take over a patient from the basic, the first responder. All right. So now this,
Hello?
yes, I want to see how I can move this down, but it will activate some of my...
Okay, you want to move the slide down?
Okay, okay, it has gone away, it has gone away. Good. So, if you get an adult cardiac arrest patient, the pathway that you follow as the ACLS team, okay, the hospital emergency response team, okay. So straight away as you get to the scene, you need to continue with the CPR because they are handing over to you a patient with cardiac arrest, or a member of the team has been the first responder and is calling for team members to come. So as soon as you arrive there, chest compressions, okay? You don't joke with the chest compression. They must continue because you don't want to interrupt them. You want to achieve high chest compression fraction. So chest compression, okay? You ensure that the airway is good and you are bagging with oxygen, and then you attach the defibrillator, the manual defibrillator now. You attach it and it monitors the pressure, okay? So once you attach the defibrillator, okay, the person who is handling the defibrillator looks at the rhythm and see what kind of rhythm, okay? If it is a VF or a pulseless VT, okay, it's a shockable rhythm. So once you identify that and it's a shockable rhythm, okay, that is VF or VT, shock straight away, okay? The treatment for VF or VT is to shock. That is the treatment, okay? The compressions and the medication, they are adjunctive to treatment to maintain the circulation and the shock. But treating the rhythm is the shock that treats VT and pulseless VT and VF. So you have to shock immediately. Once you do it, you shock. And once you deliver the shock, you don't check pulse and look at the rhythm, immediately you deliver the shock. No, as soon as you deliver the shock, back to compression, okay? Remember that you are shocking the heart. Once you shock the heart can be stunned, okay? For it to get to organize rhythm, it needs time. So you don't shock and then you wait, you're expecting to come and see, get a rhythm. Continue your compressions, okay? Continue your compressions, okay? And then you try to establish IV or interosseous access so that you'll be able to give your medications, okay? So 2 minutes from the time the last shock, the first shock has been delivered, then you have to pause to check rhythm and pulse. So check for the pulse and check the rhythm, okay? So if you check the rhythm, it's still a shockable rhythm, and you check the pulse, there is still no pulse after you do this rhythm check, you shock the patient again. Once they are still in VF or VFib and you are not getting a pulse, you shock, you deliver another shock, okay? Once you deliver that shock, you continue the compressions, okay? So after you deliver the second shock, you now start giving medications to support the circulation. So you give epinephrine, okay? It's 1 milligram, okay? They are saying you give it every 3 to 5 minutes, okay? So to synchronize with the cycle of your cardiac arrest, because you are checking the pulse every 2 minutes. So it's good to give the average. You know that you're going to give your epinephrine every 4 minutes, okay? So once you have given there, you are giving it in the next 4 minutes if the patient still remain in VT or VF, all right? So they put 3 to 5 minutes to take the average in between so that everything synchronizes, all right? So after you've given your first dose of epinephrine, okay, in the next 2 minutes, you're checking the rhythm. The patient is still in VT or VF, okay, and they do not have a pulse, shock, okay? Once the rhythm is shockable, shock it. Don't waste that, that's the treatment. And then, after you've given the first amiodarone, the next 2 minutes, if you are still having VT or VF, you start amiodarone or lidocaine. So you start to treat the arrhythmia pharmacologically as well. Okay, because when you give this pharmacological treatment, they also increase the chance of defibrillation, converting the patient to sinus rhythm when you shock them. Okay, so after the first epinephrine dose, the patient does not convert, giving another shock, you start amiodarone. Okay, if after you start the amiodarone, the patient does not still go into sinus rhythm, okay, you still have a VF or VT, shock, and after the shock, you give another dose of epinephrine. Okay, you give another dose of epinephrine, and the cycle continues. So after you've given the first dose of amiodarone, okay, which you give the first dose of 300 milligram bolus, okay, in the next 4 minutes from the initial point that you give the first amiodarone, you can give the second dose of amiodarone of 150. Okay, so you know that the medications are coming every 4 minutes, but the first medication you are giving is epinephrine. Then in the next 2 minutes, if you are still in the VF or VT, you give your amiodarone or lidocaine. Okay, if you do not get out of the VFib or VF, the next one you're going to give will be the 4 minutes for the next epinephrine will be due, you give, okay? So the next time you're going to check again, the 4 minutes for the amiodarone will be due. Now you give 150 milligram amiodarone. After the second dose of amiodarone, you should continue with infusion, okay? Whether the patient has been resuscitated or the patient continue to be in VF. After the second dose, the next 4 minutes, you should set up an IV infusion of amiodarone, okay? And you can still continue epinephrine up to the third dose. You give epinephrine, okay? And then once you are getting to the third dose of epinephrine and you've not achieved ROSC, you have to do what they call secondary survey to look for what might be the possible cause of this patient's arrhythmia. So for instance, if you see the VT you are having is a polymorphic VT, or you are having torsade point, you now have to consider giving your magnesium sulfate, which would also help in the treatment of the arrhythmia. Okay, and you want to assess the patient. Is the patient having you do a secondary survey, the patient having a pinpoint pupil, then you have to give antidote for opioids. All right, we'll talk about the secondary survey into a bit more detail. But as you are getting to the third dose of epinephrine, you must be looking and then crossing out your H's and T. Do you think the patient is still in hypoxia? You check the saturation. How is the saturation doing? Is the patient was the patient hypovolemic at that time? You can even be, as the team lead, can even be asking a few direct questions to a relative that has brought the patient. What happened? What do you know before the patient came? And then it gives you insight, because you want to find out what is causing this cardiac arrest and be able to treat the underlying. So you think through the H's and T's, okay, and then try to rule out which one might be causing the cardiac arrest. All right? Then this other pathway is for the non-shockable rhythm. Okay, so if you have a pulseless electrical activity or a systole, okay, then you don't have to shock. So you are not shocking in this pathway. All right, so you do your compressions, okay, and you give your first dose of epinephrine. All right, you continue your cardiac compressions, and then you check pulse and rhythm on the defibrillator every 2 minutes. Okay, and you continue your CPR. But here you are not shocking, but you are checking the pulse every 2 minutes, the pulse and the rhythm every 2 minutes. Or you will be giving your epinephrine every 4 minutes. Okay, so when this non-shockable rhythm, you don't give amiodarone or lidocaine. It's for VT or VF. That's when you give them. Okay, you continue to give your epinephrine every 4 minutes, and then do your secondary survey. Okay, you do your secondary survey to find out what might be a possible reversible cause for this. Okay, and then you continue to assess the patient. Sometimes you can start with a non-shockable rhythm. As you continue to resuscitate the patient, during your rhythm check, the patient, you see a shockable rhythm. Okay, once you see a shockable rhythm, all right, you come to the pathway at number 7. You give a shock. Okay, you should always know that if you see a shockable rhythm, the treatment for it is to shock. So you give a shock, okay, and then you continue in the pathway. So once you get a shockable, you give a shock. Then after the shock, you have to give amiodarone. Sorry, you have to give epinephrine. Okay, if you are still in a shockable rhythm, the next time you are checking the pulse, you should be ready to give amiodarone or lidocaine. Okay, and then the cycle continue as we did for the shockable rhythm. Okay, good. So some important things to know when you are defibrillating. Okay, so some defibrillator comes as biphasic. Okay, they'll be in the inscription by the manufacturer, and some come as monophasic. If they are monophasic, you need higher current to defibrillate, so up to 360 joules. Or if they are biphasic, anywhere from 120 to 200 joules. So those that are biphasic, usually around 200 joules is their maximum. So in that emergency setting, when you have to shock, you just dial it to the maximum, you deliver your defibrillation, because you are not going to do a synchronized shock. At any point, once you charge, the machine is charged, you have to deliver to shock the rhythm and resuscitate the patient. Okay. We'll talk about when to do cardioversion, right? And then these are the doses, of course, of your medication, okay? For us here, we tend to use a lot of amiodarone. So I am very much conversant with amiodarone. If you have lidocaine, then you can use lidocaine. So the first dose is 1 to 1.5 milligram per kilogram. Second dose, 0.5 to 7.5, even cumbersome. So now this one you have to estimate because you won't have time to weigh the patient. So you estimate for a 70 kilogram is an adult male, 70 kilogram and you administer. Okay, the amiodarone is easy. All right. So what do you do when you have a tachyarrhythmia that has a pulse? So this is where now you have to cardiovert. Okay, always don't mistake cardioversion for defibrillation. You might end up causing problems for the patient. Okay, so you have to assess the tachycardia that the patient is having. Okay, so tachyarrhythmia that will lead to circulatory compromise, they are usually at a rate above 150 per minute. Okay, so you have to assess the patient quickly, make sure you maintain airway, assess the breathing. If they are hypoxemic, you give them oxygen. Okay, connect your cardiac monitor to monitor the rhythm. Okay, and ensure that you assess, you get IV access, and you do a quick 12-lead ECG. If the rhythm is persistent and is causing hemodynamic compromise, what are the things that you look for? Are they hypotensive? Okay, are they having altered mental status? Okay, are they having signs of shock, cold peripheries? Okay, you're not able to palpate peripheral pulse. You're only able to get it centrally when you palpate the carotid. Okay, are they having ischemic chest pain suggesting myocardial ischemia? Or are they having acute heart failure, acute difficulty in breathing with pulmonary edema? Okay, if they have any of these, there is circulating hemodynamic compromise. Okay, if you have any of these, then you have to perform synchronized cardioversion emergently. Okay, so before you do the cardioversion, you must consider sedating the patient because you are delivering a shock to a conscious patient. It's painful. Okay, so you can give sedation, and sometimes they say you also give some analgesic. Okay, if they are having a regular complex, sometimes you can give adenosine to be able to sort of differentiate the rhythm and actually able to acutely slow the heart rate. Okay, but otherwise you go for the cardioversion. So you synchronize, you put your defibrillator to synchronize mode, okay, and it will synchronize to the R waves, okay. So most defibrillator, when you synchronize, when you put to synchronize mode, you'll see small dots appearing on the R wave. That tells you the sensor is identifying the R wave, okay, and then you can be able to deliver a shock. Okay, if you put it to synchronize and those dots do not appear, it means the machine has not yet synchronized properly. And if you attempt to deliver a shock, it will not deliver in that synchronized mode. So unless it has identified the QRS, and then you deliver the shock. Okay. Now, if you are having a wide QRS complex, okay, you can only consider adenosine if the rate is regular. Okay, if the rate is irregular, you don't want to give adenosine. All right. If the QRS complex are not wide, okay, so this part where the patient is not in hemodynamic compromise, okay, and the QRS complex are not wide, then basically you treat as if you are treating an SVT. All right. So the first thing is to do vagal maneuver to slow down the heart rate. If the vagal maneuver does not work, you can use adenosine. okay? And then you can now give beta blocker to sustain the rate control, and then you can consult with the expert, okay? I've put in the doses here for the various medications, so you can be able to look at those ones later, all right? So the difference, okay, from the cardiac arrest, okay, and your hemodynamic compromise is that in cardiac arrest, the patient is unconscious, not breathing, and you do not have a pulse. You can't feel a pulse. That's what differentiates. You can't feel a pulse. But if you are feeling a pulse and the patient is showing signs of hemodynamic compromise, okay, that means if you do not act quickly, they can progress to cardiac arrest. So you have to act quickly, and here you synchronize cardioversion, not defibrillation. Yes. Hello.
Sorry, go ahead. Go ahead. Someone just interrupt.
Okay.
Sorry.
All right. Let's talk about the bradycardias. Okay. Managing the bradycardia. Okay. So the same thing, you assess the patient's clinical condition, and typically bradycardia that will produce symptoms in patients are usually less than 50 beats per minute. Okay. So assess the patient, the same thing, you maintain the airway and breathing, proper oxygenation, get IV access, connect to the monitor. You do a 12-lead ECG, but you don't delay therapy for 12-lead ECG. If you're able to assess the rhythm on the monitor, but sometimes for you to properly assess the rhythm, because you know the way the waves are presented on the monitor, sometimes it can be difficult to distinguish, especially some QRS that are just borderline wide. You are not sure to make a decision whether it's a broad QRS or a narrow QRS. You have to print a 12-lead ECG to be certain. Okay, but that should not delay your therapy. All right. So the same thing, if the rhythm is persistent, okay, the patient does not have any sign of compromise, you just need to monitor them closely. But if they have signs of hemodynamic compromise, the same things that we look for in the cardiac, same things, okay? If they have that and you are dealing with a bradycardia, okay, the first thing is to give atropine, 1 milligram bolus, okay? And just like the way you use amiodarone in the tachycardia pathway, this one also you give 3 to 5 minutes. So you can give every 4 minutes. All right. So you give atropine IV. Okay. And then if you are still having the slow pulse, the next medication you consider to give medications that will support the circulation. So either dopamine or epinephrine. You start a dopamine or epinephrine infusion. Okay. So here, you don't do bolus of the dopamine or epinephrine like you start with bolus of amiodarone in the tachycardia pathway. You start infusions straight away after you've given your first dose of atropine. Now, atropine generally, it blocks acetylcholine receptors, okay?
Hello.
And then so it's basically can go up, okay? AV block. Hello?
Hello, Dr. Conteh. We actually lost you at some point.
Okay, so it's not my network. So let's hold on. He will come on back.
All right.
I think we lost him at the point where. Hello, Dr. Conteh.
Yeah.
We lost you at the point where you started talking about atropine.
Atropine, okay.
Your slide is not on.
Okay, you are seeing the slide.
No, we are not seeing anything now.
You are not seeing the slide. Okay, I need to share it. Okay. Sorry about that. Okay. So, as I was saying, generally for bradycardia, atropine, by its mechanism of action, blocking vagal effect, it will improve the heart rate. However, patients who have high degree AV block, anything from MOBITS 2, okay, to complete AV block, they tend to respond poorly to atropine, okay? They respond poorly to atropine. So those patients, okay, you can give your atropine, but you have to work assiduously towards getting a defibrillator with pacing activity, with pacing capability to start pacing those patients. Okay, start pacing those patients. Okay, otherwise, if when they do not respond to your initial atropine and dopamine, you have to consider the transvenous pacing. But in the emergency setting, you can do transcutaneous pacing, okay, which we're going to talk about now. So transcutaneous pacing in the emergency setting, okay. So you can be able to achieve pacing non-invasively by your defibrillator, okay, especially in the emergency setting, when you don't have time to be able to put a temporary transvenous pacemaker, okay? So, as I said earlier on, you should consider doing transcutaneous pacing in high degree AV block when IV access is not available, or you've given atropine and is not working. You have to consider transcutaneous pacing, okay? So before you pace the patient, especially if the patient is conscious, you have to make sure you give analgesia and sedate the patient for pain control, because you'll be delivering shock continuously to the patient. It can be very painful, and it's not a good feeling. Imagine electric current going through your body and you are conscious knowing it. It's not a good experience. Okay, so when you are doing transcutaneous pacing, you have to make sure that you give a good analgesic and the patient is conscious, you sedate them. Okay, and after you initiate transcutaneous pacing, okay, you must confirm mechanical capture, right? So electrical capture, you have to look at the monitor you have to look at the ECG strip on the monitor. Okay? Like what you're seeing, you should be seeing pace, you should be seeing pacing spike, followed by a broad complex, a broad QRS complex. Pacing spike followed by a broad complex. Then you know that the pacemaker is releasing current and it's being captured by the patient's heart, okay? And then you should see the patient's heart rate going at the rate at which you set your pacemaker on the defibrillator. Then you know that there is electrical capture, okay? Apart from electrical capture, you have to ensure that there is also mechanical capture. Mechanical capture, that means you should be able to feel a pulse, okay? You should be able to feel a pulse. So you check the pulse. Then importantly, okay, so this is one peculiarity about transcutaneous pacing in ACLS. All the time when we are talking about resuscitating a patient responding, we're saying go for the carotid pulse. But when you are doing transcutaneous pacing, you don't use the carotid pulse because you see where the pads are, especially this one up here. When this one release current, it can cause muscle twitch, even in the sternocleidomastoid. And if you are palpating there for pulse, you can palpate the muscle twitch and think they are pulse. Okay? So once you are doing transcutaneous pacing, don't use carotid pulse. You go for the radial pulse, okay? Or you can do a femoral pulse and palpate the femoral, but do carotid pulse. It might be misleading, right? So once when you start to pace, okay, you set the amperage, the voltage, okay? You increase the voltage. You start with a low voltage. You continue to increase until you see electrical capture. And when you see electrical capture, you go 2 milliamps above that level, and then you set the pacing amplitude at that level. Okay? And then for the heart rate, you have to set it at the lowest effective rate based on the clinical assessment of the patient. So the lowest rate wherein you can feel a pulse, and then reversal of the hemodynamic compromise is happening. Okay? The patient is less agitated, not confused. You can feel regular pulse. You're able to check the blood pressure, and they have a blood pressure. Then you pace at that rate. Especially for patients who have suffered myocardial infarction and they go into heart block and you are pacing them, you want to really pace them slow. You don't want to go fast, and then you increase oxygen demand again for the patient. So you have to pace at the lowest effective rate based on the clinical context of the patient or your clinical assessment. Okay, good. Now, how do you assess response to the pacing? Okay, so your goal of pacing the patient is to reverse the hemodynamic compromise. Okay, so all those things that constitute hemodynamic compromise, you have to assess for them and make sure that they are reversed. Okay, you are not targeting any particular heart rate. That is very important. You want to pace at the rate that will, sustain the patient, make the patient hemodynamically stable. Okay, so generally, we advise that you start with a pace rate of between 60 to 80, and then you adjust based on the clinical response of the patient. All right, and as we said, acute coronary syndrome patients, they should be paced at the lowest heart rate that allow clinical stability so that you don't further increase oxygen demand. All right. So what are some of the precautions that you should take when you want to do transcutaneous pacing? Okay. When you have a patient with severe hypothermia, the slowing of the heart is part of the response to the severe hypothermia. You don't pace those patients. Okay. You don't pace them at all. You actually manage the temperature. You improve the core body temperature. All right. If the patient is conscious, you must give them analgesia. Okay. Except if they getting the analgesia or sedative is going to delay you and the patient is deteriorating, then you can start your pacing and get the analgesia. Okay. But you need to make sure that you give them analgesia. It's not a good experience. To be very, very much conscious and you are being shocked. The normal way your heart should be beating, you are receiving shock every time. It's not a good experience at all. Okay, and again, this emphasizes that you do not assess the carotid for mechanical capture because you can get twitching there because of the pacing, and then you can mistake it for a pulse. Good. Then there's what is called standby transcutaneous pacing. Okay, so this we do it for patients who've suffered ischemic, who have suffered acute coronary syndrome and they have a severe bradycardia. Okay, Those patients who have suffered acute coronary syndrome and they have a severe bradycardia, okay, even if they are stable, it is possible that they may decompensate or become unstable within minutes, okay? Because the conduction, once the conduction system is affected, it can just stop conducting, okay? So in those patients, you should just put the pacing part there on standby, okay? You put the pacing part there on standby because you know they may deteriorate. So anytime you get an ACLS patient that has symptomatic sinus node dysfunction with severe bradycardia, you have to stand by your pads because they can deteriorate and become hemodynamically stable. If they present with asymptomatic MOBIT 2, just put your pads on standby. They might actually just progress to complete heart block and go into very severe bradycardia. Okay. If they also already now have asymptomatic complete heart block, be on standby because the ventricular escape might just fail and you need to pace the patient. Okay. And also if they suffer an ACS and they get a newly acquired LBB, ILBB, or alternating bundle branch block, or even a bifascicular block, you know that the conduction system is compromised. Get your pads ready. So no sooner their condition change, you are ready to start pacing. That's not the time you begin to run around to find the defibrillator with pacing capacity. All right. So now the post-cardiac arrest, that's the last thing that we'll cover. Okay. So for the post-cardiac arrest, all right, once you attain spontaneous circulation, so WASC is return of spontaneous circulation. Once you achieve that, okay, the same thing, you have to continue managing the airway. Because when you get spontaneous circulation, that means you have a pulse, okay, and you can have a blood pressure, you can read a blood pressure. So, but they might still not be breathing spontaneously, so you still have to manage the airway, okay? So you maintain them on 10 breaths per minute or 1 breath every 6 seconds, okay? You aim for SpO2 90 to 98%, okay? And carbon dioxide partial pressure between 35 to 45, okay? And then manage the hemodynamic parameters. So you can give fluids if they to maintain your blood pressure above 90, your systolic blood pressure above 90, and mean arterial blood pressure above 65. Okay. So immediately after a patient survives a cardiac arrest, you have attained spontaneous circulation. You have to ensure that you do an ECG, a 12-lead ECG. It's very, very important because the patients maybe that you started with a VTAC or a VFib, it might be an acute myocardial infarction that has triggered that VTAC or VFib. So immediately you are able to attain ROSC, you have to do a 12-lead ECG to rule out possible cause. You can see signs to suggest a PE on the ECG. P was what was triggering it. Okay. You can even see signs of certain electrolyte imbalance, okay, that you can continue to treat. So the 12-lead ECG, immediately the patient, you achieve spontaneous circulation, you have to do a 12-lead ECG, okay? So depending on the results of your ECG, if they are, you can consider certain interventions. So if the patient has a STEMI, you alert cath lab for the patient to be taken into cath lab, okay? If the patient is in unstable and in cardiogenic shock, okay, where the facilities are available, you can actually alert for that patient maybe to have an intra-aortic balloon pump or a left ventricular assisted device, whatever, okay, for your mechanical circulatory support, right? Then once you've done your 12-lead ECG, you take appropriate action, you assess the patient, okay, for consciousness. If the patient is following commands, then you know that the patient is awake, okay? So you just continue with the critical care management and observe the patient in the intensive care. Okay. But if the patient is comatose, then you have to do targeted temperature management for at least the first 24 hours. Okay. You want to maintain your temperature between 32 to 36 degrees. Okay. And depending on the initial presentation of the patient, you want to go more towards the lower temperature or towards the 36 degrees. All right. So those who are comatose, after you've done your, you need to obtain a brain CT scan to see whether the patient has suffered ischemic brain injury. Can do EEG monitoring as well for seizures and all. Okay. And of course, your other critical care management, make sure if the patient needs ventilation, they are on ventilation, and all your monitors can set a central venous pressure monitoring line or an arterial line to monitor the patient in intensive care. Okay. And at this stage again, you go through your H's and T's to treat immediately reversible condition. So whether you're having electrolyte problem, your hyperkalemia, saturation problems, okay, you can manage with intubation. All right, you're having temperature problem, hypothermia, you manage by increasing core temperature. Okay. All right. Or if you are having signs of myocardial infarction or pulmonary embolism, you have to manage accordingly. Right. So this one basically, you read in terms of the temperature, targeted temperature management is of high priority. Okay. And as I said, between 32 to 36 degrees for 24 hours. Okay. By ensuring that you cool the patient. Use a cooling device. Some people use IV fluids, certain temperature, and people can use packs, ice packs to the body to maintain the core temperature. And you monitor either esophageal temperature or bladder catheter or even rectal catheter, rectal thermometers to monitor the temperature. Okay. So that's the post cardiac arrest care. So now, the last thing we'll talk about, how do you decide to stop resuscitating a patient? Okay, how do you terminate a patient? So in the out of hospital setting, okay, if the patient arrested and there was no witness, no bystander, okay, and then you went to the scene, there is no return of spontaneous circulation before transport of the patient, okay, and no shock was delivered, basically nothing was done for the patient, okay. If all of those criteria are present, then you have to terminate this, or the patient, I mean, would have already suffered sudden cardiac death, okay. But if any of this is missing, if the patient was attended to, the patient had received a shock, when you receive the patient, you have to continue resuscitation within the in-hospital setting, okay. But for the in-hospital protocol, if you started the resuscitation in the in-hospital setting, there are a lot of other things that you need to consider before stopping resuscitation. And in that case, you have to follow guidelines of the facility where you work. Every facility have their guidelines for stopping resuscitation, okay? So it's not a one-person decision. Most times the team lead has to take that decision, and you even need to involve other consultants to decide that you need to stop CPR, okay? So there are ethical and legal considerations, okay, that you need to consider, all right? Whether the patient has a policy of, has signed a do not resuscitate policy, and what's the hospital that they're working their own policy on resuscitation, okay? So all of those you have to take into account. Importantly also, the underlying condition, okay? For instance, a patient who have suffered an extensive myocardial infarction, okay, left main coronary artery, did not get reperfusion therapy, okay, and then they go into cardiac arrest. You resuscitate, 20 minutes, still nothing. Okay? So you know that this patient, even if I attain ROSC, it will be for a very short while. So you might want to terminate your CPR in such a patient. But if you have a young patient, fit patient, but then overdose on a medication, and you are resuscitating, you'll be resuscitating for 20 minutes, still not achieving ROSC. You still want to continue as you treat the overdose. So that is a healthy patient without heart condition. There is likelihood that even if it takes long, you'll be able to achieve ROSC, the heart will be able to continue. So the underlying medical condition is very, very important in terms of making your decision. Okay, and the cause of the cardiac arrest also is important. Okay, then also the facility factors are very important. The resources available for the post-cardiac arrest care. Okay, a patient in persistent vegetative state, you are resuscitating this patient, is going to occupy your ventilator, is a patient who has a cancer and has less than 6 months to live. And then you resuscitate the patient, even achieve ROSC, and have to keep the patient on a ventilator to die in the next few months. You have to consider all those, and you have other patients who are acutely ill, who have better chance of long-term survival if they have, access to those ventilators. So all of those things, the resources that you need post-cardiac arrest, all must be taken into consideration when you are taking a decision not to continue to resuscitate patients. Okay. There's also you look at the invasive assessment of the quality of CPR. So they do what is called end-tidal partial pressure of carbon dioxide. Okay. So when those values are low, it shows that spontaneous respiration is not on, and the CPR, was not of high quality that has been done for the patient. So when you get those very low values, you know that the chance of recovery of this patient is very low. So that can also influence your decision whether to continue with the resuscitation or to terminate the resuscitation. So these are all tools that you use. So those are my references, and we can take questions.
Wow. Wow. Thank you so much, Dr. Conteh, for another excellent presentation. As always, the presentations have actually made a lot of stuff easier and clearer, but I'm sure there are questions in the minds of the participants. So the floor is open. If you have questions to ask, please, you can unmute your mic and ask. We can start with anybody. Thank you again, Dr. Conteh. Very brilliant. Any questions for anyone, please? Okay, before somebody asks, Dr. Conteh, thank you. What's the maximum energy you can give in the rounds of shock? Sometimes I used to have this mindset or understanding that once you get above 3 shocks, you should stop. But it seems from your presentation, you can give shocks infinitely. So what's your take on that?
So when you are defibrillating, you go for the maximum energy to ensure that you convert the patient back to science. So you need high energy to defibrillate the patient. Okay, but when you are cardioverting, you need moderate amount of energy, and there are various different quotation from different authors based on the type of breathings. Okay, and also based on the body weight of the patient that you're shocking. But generally, for defibrillation, your maximum, most of the time you have to go dial it to the maximum on the defibrillator. If they are biphasic, they'll be the maximum around 200. Some can be just 150. Okay. If it is monophasic, then you have to go up to 360 to defibrillate. Okay, and if you are cardioverting, then you have to consider the type of rhythm and then the body weight of the patient as well, determine the amount of energy that you use to shock the patient. But you must know that when you are cardioverting, you have to use less amount of energy compared to when you are defibrillating.
Okay, from what I read for cardioversion, I learned that for cardioversion we can start from 50 joules and migrate upward. Yeah, so I'm just thinking, what do you think? Because you didn't mention. Yeah.
Yes. So for the ventricular tachycardia, so you have to start from above 100 joules for adult patients. So some of the atrial tachycardia, you can start as low as 50 joules. But usually with atrial fibrillation, you need higher energy like you do for ventricular rhythms. Okay. And sometimes, especially for atrial fibrillation, to reduce the amount of time you're going to shock and get a faint shock and then have to dial up, they advise you to start with a higher joule of about 100 to 120, and then deliver the shock. But generally, the ventricular, you go higher, 100, and then the atrial rhythm, then you can, and supraventricular rhythms, you can start from 50, dialing up.
Yeah, actually, for the supraventricular rhythm, atrial tachycardia and atrial flutter, I saw when I read it was 50 joules. I think AF was 100, and then VTAC was 100, 100, 120. You see somebody else wants to ask a question. I'm just using that to stimulate talking. So, Dr. Ade, is it Ade Pimpe? Please, you can unmute and ask your question, please.
Hello, sorry, I wanted to make a contribution. This is Eugene Ampofo. And with respect to the choice of energy, if I'm allowed to go ahead.
Please do, please do.
All right, thank you, Dr. Conteh, for the presentation. So with the choice of energy, currently, there is actually a recommendation by the AHA to determine the choice of energy based on the defibrillator you are using. The new defibrillators are expected to have their specific energy per the specific rhythms. However, to make it simple, the wider the KRS complex, the higher the energy. The narrow complex, the lower the energy. The more irregular, the higher the energy. The more regular, the lower the energy. So typically for an atrial flutter, it's a narrow complex regular rhythm. So you start with 50 joules. Then you can increase if the first cardioversion fails. For atrial fibrillation, though it's narrow complex, it's irregular. So the recommendation by the AHA as at the 2020 guidelines is 120 to 200. Whereas for the ventricular arrhythmias and others, it starts from 100. So usually we simplify it. If you are not sure, you can't memorize these things, just start with 100. 100 cuts across. 100 can do for both narrow complex regular, irregular, or wide complex regular, to keep it simple. So that is the principle behind the energies. But currently, the recommendation is to look at your defibrillator and look at the specific energy recommended by the defib manufacturer. Thank you.
Wow, that's brilliant. Thank you for simplifying it. You know, before this now, I just crammed it. But I think now I have an understanding why those energy joules were given. Because when I read it, I was just actually memorizing it. Thank you so much. All right, that's Eugene. Eugene, is it your name still as Ade Pimpe or something?
No, it's Ampofo, AMPOFO.
Oh, okay. So, but somebody, the person on mute and speak, please. Ade Pimpe, thank you. Go ahead, please.
Good evening. Oh, I don't have any questions. Thank you, Dr. Conteh, for the wonderful presentation. Thank you.
All right, that's beautiful. Dr. Adebi.
Well, thank you, Dr. Conteh, for the brilliant presentation. It was quite explicit. So I once had read also that actually for the assessment of the defibrillator, the AED, that you can use a 2 minutes or you can also use 5 cardiac cycles. That at the end of each 5 cardiac cycle, you can actually assess. And each cycle is when you do a 30 compression and 2 rescue breath, that's 1 cycle. So you do 5 of that in a series. So that it is equivalent to 2 minutes, just in case we find that in MCQ. So you can use 5 cardiac cycles. If you don't want to use the word 2 minutes. So that,
yeah, definitely. I mean, it's come down to the same thing. And they can twist these things, especially in MCQs.
yes.
So 5 cardiac cycle of 30 compression, 2 breath. You do it 5 times equivalent to 2 minutes.
Yeah.
Okay.
It's the person that did the last compression that will assess the carotid position before that switch of you are going in a counterclockwise direction. So the person that just finished the compression quickly check the carotid position, then switch. The next person comes in that particular.
Okay. Okay.
Thank you very much. I also want to make some other contributions. I believe when Dr. Conteh was showing the algorithm for the ACLS cardiac arrest, it looked a lot, but you can keep it simple. So for the shockable rhythms, okay, medications come in after the second shock. Okay. Yeah. So after the second shock, just consider this to keep it simple. Like you said, you are doing rhythm and pulse check every 2 minutes. So even though they are recommending epinephrine every 3 to 5 minutes, ignore the odd numbers. It makes it difficult. Just stick to 4 minutes. So every other minute, you may give a medication. Now, the concern is which medications do you give? Now, starting from the second shock, all the even numbers, all the even shocks, you give adrenaline or epinephrine, meaning shocks 2, 4, 6, adrenaline. Shocks 3, 5, 7 is amiodarone or lidocaine. Simple. That way you don't get confused. And if you follow it and you look at it, it fits exactly the same.
Please
so from the second shock,
run it again.
Dr. Eugene, please, can you go over it again in a slow version?
Okay. So from the second shock, that is when medication starts in ACLS. The first shock, there's no medication. So it's the second shock. So if you look at the algorithm from the second shock, that's where epinephrine comes in, and you're supposed to give it every 3 to 5 minutes. But if you follow the algorithm, you notice that if you give a shock and you give epinephrine, and in the next rhythm and pulse check, okay, which is if it's up to 4 minutes from the first dose of adrenaline, the medication that comes along is amiodarone or lidocaine. But it makes it a bit cumbersome to memorize it that way. So look at this way. Since medication is starting from the second shock, for all the even number shocks, i.e., if the shock is from 2, 4, 6, okay, because you're giving first shock, so second shock, third shock, fourth shock, assuming you run the CPR for that long. So all the even number shocks go with epinephrine, and all the odd number shocks go with amiodarone or lidocaine, and it will fit perfectly.
Okay, all right. I get it clearly now. All right. But if you don't have, yeah, it's clear.
So that it makes the algorithm simple. So if you move
second shock, and let me just see if I can get clearly. We're starting from the second shock. So shock 2 is when we're starting. So shock 4 would be for my adrenaline.
Yes. And the first shock would have been amiodarone or lidocaine. Then the fifth shock would be amiodarone or lidocaine. The sixth shock would be adrenaline. Yeah. So 2, 4, 6. So you keep it like that. It's simple.
So after the fourth shock, I will be giving my adrenaline. After the third shock, okay.
Amiodarone or lidocaine.
Amiodarone or lidocaine. But that second shock, I should have started my adrenaline after that second shock.
So the adrenaline can go before or after the shock. It depends on how good your team is. Adrenaline should go with the second shock. So either you give it before the shock or after the shock. It just has to go with the shock, but your coordination should be well such that you don't end up shocking the one giving the medication. So to keep it simple, you can give it after the shock, but definitely when you make the decision that you are going to shock and it's your second shock, you know the medication has to go along with it. So it depends on how fast like you said, you pre-charge 15 seconds to the rhythm and pulse check to save time. So if you have a very coordinated team, they can pre-charge 15 seconds, shock, and the medication goes. That is if all team members are trained, it's quite easy and effective. But if you are not that, just wait for the shock to go and safely give your medication. And one of the other roles that is also currently mentioned is what we call the CPR coach. So there's the typical foundation team roles and team dynamics he mentioned: airway, team leader, timer with recorder, chest compressions, monitor. Those are the foundation, but that's what we call the CPR coach. In the 2015 AHA, it was a team leader who was literally also monitoring the high quality CPR, the components that he discussed. But it's a lot of work to be a team leader and at the same time monitoring whether they are doing 100 to 120 compression, depth of 5 cm, recoil, etc. So the CPR coach essentially is one person who is just monitoring these characteristics of the high quality CPR he described. So that CPR coach can be a 7-person, or the one at the monitor can act as a CPR coach. And his or her job is to ensure that the chest compression is being done in terms of the characteristics of high quality, so that the team leader can focus on the other aspects of the CPR. So if you hear of a CPR coach, essentially that is what it's about. CPR coach, that's also another role. And like my other colleague mentioned, if you don't have a timer, you can use the 5 cycles. 5 cycles, if you are doing it well, should be equal to 2 minutes. And the AED technically will not determine whether the patient has a pulse or not. The AED mostly will determine whether the rhythm is shockable or not. So it means that your patient might have achieved ROSC, i.e. will have a pulse. And during the rhythm and pulse, during the AED analysis, the AED will say do not shock. So if you are a health worker using an AED, because you are trained, you have knowledge, you can then also be assessing the pulse. But technically, if you are teaching DLS, assessing pulse during the AED assessment is not part. The pulse comes in when you are doing the initial assessment to determine whether the patient is responsive, unresponsive, cardiac arrest or not, for you to progress. But the AED will just tell you, analyzing rhythm, do not touch patient, shock advice, shock not advice, resume CPR. It technically does not tell you whether there's a pulse or not. So you should also note that. And the AED, when you are using the AED, you should know your AED. Some AEDs, if they say do not touch patient, do not touch patient. If you touch the patient, it confuses the AED. Some AEDs, you can actually be doing chest compression whilst it's analyzing the rhythm. So you need to know your AED. Most AEDs, if they're analyzing rhythm and you do chest compression, it confuses it. And do not try and go ahead of your AED. The AED has been designed to be very basic for anybody to be able to use. So sometimes even if you put it on, it will tell you take off clothing. It's even assuming that clothing has not been taken off, because it's assuming the person who is even using the AED may not be a health worker. So we always say to use AED, you should just be able to understand English or the language in which the AED was designed, and you should be able to use an AED. Just power it on and follow the steps. Don't go ahead of it if you don't know the AED, because immediately you go ahead of it, it can confuse the AED and it will stay at this one command and keep repeating itself over and over and over again. So that's my comment. And like Dr. Conteh said, if you are a health worker trained, you don't want to use the AED because the AED takes time. If you are using a manual defibrillator, you're able to determine your rhythm early and decide whether it's shockable or not. The AED can spend minutes just saying, analyzing rhythm, analyzing rhythm, analyzing rhythm. So as much as possible, practicability, if you're in the hospital, use a defib. It saves time and it buys time. And like Dr. Conteh said, quickly you want to early defibrillate and minimize interruptions to less than 10 seconds. Thank you.
Wow, that's brilliant again. Thank you, Eugene. Dr. Olalekon, Please, you can unmute and comment or ask a question.
Okay, thank you. Good evening. Thank you, Dr. Conteh, for the presentation. Okay, my question is actually, the assessing for breathing in the patient. What's the best way to go about it?
Assessing for
breathing in the patient. Yes, for circulation, you have to palpate the carotid artery pulsation, just like you rightly said. But how best can one assess for breathing? That's number one. Then number two is that I think I came across these. I don't know whether this is part of the new guideline talking about Dr. Cab. I don't know whether that actually fits in here. DRCAB, following that algorithm to assess a patient that probably has a cardiac arrest. I don't know whether you got my comment.
But I don't understand the second
okay,
comment. I don't understand.
Before, I think they talk about is it the circulation? No, sorry, ABC. I'm talking about airway, breathing, circulation. But now, now what you put down, I think the first thing is to danger. I think danger, rescue, then the circulation, airway, and then the breathing. I don't know what you have to say about that. Or probably you came across something like that.
Okay, yeah, it's just the result. Like what I mentioned in the BLS, that once you are the single responder, you get to the first thing is to assess the safety of the scene, which is called your danger. Okay, and then you check the patients, make sure that whether they are responsive or not. That will be your R. Okay, and whether they are unconscious, then you go ahead now and check your airway and whether they are breathing or circulation. So in terms of checking the breathing, okay, so if a person is breathing spontaneously, you should see chest rise and fall when they are breathing. Okay, so when you are responding to unconscious patients, you actually have 10 seconds to check your pulse and the breathing, and then decide to, because you want to start chest compressions. Chest compression is the key, is what is maintaining perfusion to your vital organs. So you don't want to waste time. So once you call and hit the patient, they do not respond. Your hand goes to the pulse and you are looking at the patient's chest for chest rise and you are feeling. 10 seconds, you should have made an assessment. If the chest does not rise and fall within 10 seconds, know that you are dealing with a cardiac arrest. Your chest compressions start immediately. So you are looking mainly at the chest rise and fall for the breathing. That's what you're looking at.
Thank you.
Dr. Laleko, are you okay?
Yeah, I am. Thank you.
And I also want to hear the second part of the question, the CAB. The reason why it was now CAB from the usual ABC is that in adults, the commonest cause of cardiac arrest is cardiac, compared to children or pediatrics, where the commonest cause of cardiac arrest is airway hypoxia. So the idea is that if the person does not have a respiratory issue, which is most commonly not the primary in adults, there's a reserve. You have a reserve oxygen that can be circulated. And that is why the emphasis is on the compressions to circulate that oxygen reserve to vital tissues to preserve brain function. Then you can now augment with the rescue breaths. So the cardiac compression is the foundation because we are simulating the physiology. And because the commonest cause is not mainly hypoxic in adults. So the compressions goes, circulates the residual oxygen, then later you top up. So that's the reason why it was changed from ABC to CAB mainly in adults. Thank you.
Okay, so you mean that the CAB means you check for circulation first, then breathing. If you go upward that way,
yeah, so if you want to separate it, but like Dr. Conteh said, usually we check the circulation and the breathing at the same time. But they wanted to emphasize on the CAB because most people were still focusing on airway before checking the absence or presence of central pulsation and initiating the chest compression. So they made the CAB to emphasize that chest compression is the foundation, is the key, is the go-to. before trying to get a rescue breath. So that's why there's what we call chest compression only CPR. So when you don't have a barrier device or a pocket mask and you're a single rescuer and you don't want to risk mouth to mouth, you can actually do chest compression only CPR. And that is the basic, the science behind it, that there's still some residual oxygen to circulate.
Why you are doing that? Okay. Well, compression, would you want to chain lead just or just compression, even though some high level?
Sorry, the line is breaking, so I lost you briefly.
Okay, let me come. You said about my network. People have attacked. Clearly. Hello.
Yeah, I think it's clear now.
Oh, for adults, most common cause, and there's still some residual volume of oxygen for cycling and oxygenation. So you can do only pieces. Does it get there, patient? Just your won't bother to raise up the airways and pattern, and just go ahead.
I still had bits and bits of it, but I
Your
still had
network
bits on
is
that.
poor,
But
Dr. Kobe.
you are trying to say whether you should still open the airway whilst you are doing the chest compression only. I think that's what you're trying to ask.
Yes.
So
Yeah,
to do that as a single rescuer, even if you open the airway and you adjust it and you go back to chest compression, it's going to fall back. You're going to lose that. So if you are a single rescuer, then you focus on the chest compression only, because if you're not going to give the rescue breath, you can't keep the patient's head in that posture, head till chin lift, in that position. You'll still lose it if you go back to chest compression. If you're a single rescuer and you're not ready in this era of COVID or anything to risk it, and you don't have a pocket mask, then you are allowed, there's evidence to support chest compression only CPR.
So in that time of doing your chest compression, would you do 30 and wait, or you just continue doing?
No, continuous chest compression. And in fact, just for mentioning that, when you put in the advanced airway, i.e. an LMA or ET tube, or the other forms of advanced airway, it's no more 32. It's continuous chest compression, and you give rescue breath every 6 seconds. So immediately you advance your airway to a supraglottic airway, i.e. LMA, ET tube, either cuffed or not cuffed, or esophagotracheal tube, any advanced airway you put in, you move your chest compression to continuous chest compression, and you give a rescue breath every 6 seconds.
Okay. All right. Wow. All right. So Dr. John Onyebweze Gochukwuigwe, Sir President, you want to say something?
I think I commend the person that did the presentation, and then the other contributions. He has made it very, very clear, very, very clear with the BLS and then the ACLS. It's very clear now.
Okay. Wow. Thank you, sir. Any further contribution, Dr. Fatima? Are you there, or you've gone home?
I'm there. I'm not feeling fine. Having fever,
Okay.
Well done, Dr. Conteh. It was an excellent presentation. I don't have comments. Thank you very much.
All right, that's fine. Dr. Jennifer. All right. Dr. Adebi, please, this is a high quality material. So if you don't mind, if you can help us put the recording early so that we can speak. Dr. Godia, Mr. President, sir, you wanted to do something.
Yeah, Chief of Copy, thank you very much. Dr. Conteh, thank you again for a well-delivered CPR discussion. So I wanted to find out 2 or 3 things because I don't know whether you've come across something called malignant arrhythmias. And there was a question that I saw somewhere said define malignant arrhythmias, then give 3 malignant arrhythmias. So I don't know if ventricular flutter should be there and also should be part of when someone is discussing CPR. And yeah, whether that can go as the third causes of circulatory collapse that will require CPR. So okay, I think the other points I wanted to raise, it has been cleared. So I think this is the one that need to clear it. Thank you.
I've not come across specifically the description of malignant arrhythmias, but for arrhythmias that require resuscitation, okay, so basically any rhythm can result in cardiac arrest depending on what the underlying causes, okay, because sometimes you can get pulseless electrical activity. You see what looks like organized rhythm, but then the bottom line is the patient is unconscious, they are not breathing, and you are not palpating a pulse. So it becomes a rhythm that you need to, it becomes a situation that you need to resuscitate the patient, and you need to do your chest compressions, okay? But generally, the VTAC and the VFib, the VTAC and VFib and the pulseless VTAC are the 2 main tachyarrhythmias that are the common causes of cardiac arrest. And then for the bradyarrhythmias, obviously, your complete heart block can cause people to frequently go into cardiac arrest. I don't know, maybe Eugene, if you have something to say about the malignant arrhythmias.
Yeah, so thank you. So the malignant arrhythmias are essentially the same components you described. You typically refer to VT, VF, and also torsade point, arrhythmias that usually will result in hemodynamic compromise and can cause cardiac arrest. I don't know of any other definition, but I think we can cross-check and see. But usually, malignant arrhythmias refers to usually ventricular arrhythmias.
Yeah, that's the definition.
Yeah, it's true. So if we take what is it called now? Torsade de Pont, Torsade de Pontis is also a form of a ventricular tachycardia. So, sorry, a ventricular fibrillation. So if you've said VFib, do you sorry, VTAC rather? If you have said
is a VTAC, is a VTAC.
Yeah, yes, that's what I'm saying. So if you have said that VTAC, VFib, do you need to say torsade de Pont again? Because it will mean saying the same thing double.
Okay, so my response to that is
the question was specific. They were very specific. I think it was the April exams oral. So they give 3 malignant arrhythmias and how you manage them. So in that situation, I don't know if this concept of ventricular flutter can be the thought, but I have not come across. That's why I feel since this discussion is going on, maybe someone would have come across it.
If I may,
what I'm thinking is that maybe you can separate the VTs. So you get VF, then monomorphic and polymorphic VTs.
Yeah. And I
which
think the
is
reason why the Tosa the point maybe of a good mention is the peculiarity in the use of magnesium in its management. So I think if you are able to mention it, throwing that in will be a bit helpful, because typically for the VTs in general, you may not give MAC. But if you are setting a Tosa the point, then the magnesium becomes critical in part of the management. And also like the monomorphic and polymorphic VT, another importance is that even if you have a patient who has polymorphic VT with a pulse and is stable, you cannot synchronize cardioverse a polymorphic VT. That is one exception you should note. So if you have a scenario, a patient with polymorphic VT with a pulse, you cannot synchronize cardioverse because the DFIPs cannot pick the peak of an ACLS complex in polymorphic VT. So stable or unstable, you defibrillate. You do an unsynchronized cardioversion because you cannot synchronize cardioverse a polymorphic VT. So that is the exception. So maybe if it's a viva discussion, then that may come along the line. You can discuss it along that. I don't know whether that is what the examiners wanted in specifically, but for polymorphic VT, you cannot synchronize cardioverse a polymorphic VT. You have to defibrillate.
Okay, so all the three of the polymorphic VTs, i.e. bidirectional, Tosa the point, and what's this other one called again? So all of them is is
defibrillation. You cannot cardiovert polymorphic VT. Yeah.
Okay.
Because the defib cannot pick the peak of the R wave to give a synchronized cardioversion. And another caveat is that when you are synchronizing cardioverting a patient, you do not just release the energy and take off the parts. You know, when you do a defibrillation or unsynchronized cardioversion, the energy is delivered immediately. So clear, charge, boom, then the energy goes. But if you're doing synchronized cardioversion, after pressing the release buttons, you hold the pad in place. Sometimes it may take a while before the energy is delivered because the software is trying to detect the peak of the R wave. So when you're synchronizing cardioversion, you hold the pads in place and you release the energy. If it's not cardioverting, you just stay there, don't move. Because especially if you are cardioverting an irregular rhythm like an AF or a flutter with variable block, you release and hold until it takes the peak of the R wave. It will not release the energy. So you may think your defib is not working, but you have given a command to the defib to synchronize cardiovert until it picks the peak of the R wave. It won't deliver the energy. Unlike on synchronize, immediately you release the energy, boom, it jabs the patient.
So this stuff you just mentioned is so timely for me, because it was a time when the ICU and we needed to cardiovert, and we pressed, nothing was coming out. I just thought probably there was a problem. And
no, it happens. So it means that your rhythm is so irregular that the defib is unable to pick the peak of the R wave to deliver the energy. So you have to be patient until it picks the peak of the R wave.
And since if it's a polymorphic, it may never pick. So
no, I think, so polymorphic you defib, you don't even synchronize. You defib straight away.
And then pulseless monomorphic is still defib.
Yes, defib. It's a shockable rhythm.
Yes. Now
just to mention something. One thing that I saw when I was reading is that they advise, you see the way you can pick the poddles and then hold them and then charge whilst you are holding the poddle. They are advising that if you are going to do synchronized cardioversion, you don't pick the puddles. You leave the puddles, you synchronize, and then until you are sure you achieve synchronization by seeing the points on the RR, then you pick the puddles and go to deliver the shock.
Yes. But even with that, you can still see the synchronizing dots, put it there, and it may still not discharge like he mentioned. Because sometimes if you look at the KRS complete during the synchronization, there are points that actually you don't see the dots on the KRS complete. So you see dot, and there are periods you won't see, and there are periods you see. So if you release the energy at the point where it was in the cycle where those dots were not there, to not release until it picks the dots.
Okay, sorry, I don't know if I will ask this question now. Maybe I just pray it doesn't distract us. But Dr. Goodyear, are you okay with responses?
Yeah, okay.
Okay, my next question is with respect to part placement. Sorry, this is my extra reading I was reading. With respect to part placement, what is the ideal? I learned that right lower sternum and just below the nipple, before the axilla, and then some left behind the axillary line for certain conditions like when there's breast cancer and some other stuff. Can you throw more light on placement of the parts for defibrillation and placement of the part for cardioversion?
So basically, the position, whether you are defibrillating or cardioverting, is the same. What you want to achieve when you are releasing a biphasic current from the base of the heart to the apex, that's what you want to be in line so that the current moves through the heart. Okay, so the one pad is, like you mentioned, towards the apex of the heart, the axillary line. Okay, and then the other part on the chest wall. Okay, around the sternal area. Okay, and then so the other thing, a lot of the machines, the exact positioning of the pod is described on the puddle, or if you are using the pads for pacing or defibrillation, then the position, the exact placement of the pad is described on it. So you actually have to go with what the manufacturer put. But generally, you just want to put the apex and the base of the heart in line as you deliver the current.
Okay, because if you see some of the directions for pad,
yes,
I've seen some for right lower sternal and the axillary port, and then some for left lower sternal and axillary line, and then the one that you describe for the pacemaker for pacing and cardioversion for pacing, where you put it at the same axillary line and then towards the upper left sternal region where you cannot check the carotid. So I'm just wondering if they are all together, or it's one for pacing and then one is for defibrillating, and then also for special cases like a pregnant woman, is it the same?
Okay, so if I may come in, the AHA has two main part placements. Similar, the one you described, the typical one Dr. Conteh described, and there's what we call anterior-posterior part placement, anterior, mid, and the back. But that is more for pediatric population or children who are small. You can use that in pregnant women if you have to. Pregnant women, ideally, CPR is done in the left lateral position.
Because remember, when you are resuscitating pregnant women, sorry, Eugene, when you are resuscitating pregnant women, you have to tilt the pregnancy to the side to relieve, the IVC to ensure venous return. And so because you are tilting, you are better off holding the pad anteriorly and posteriorly, rather than going when they are already left lateral, going to put the pad over the left axillary area.
Okay,
yes, so
all right, yeah,
that's the explanation. And also one thing we should remember that in pregnancy, there's something we call, if you're doing a CPR for a pregnant woman, you have to consider the obstetric resuscitation team and also perimotum CS. So if you do a CPR for a pregnant woman for more than 5 minutes and you've not achieved ROSC, that baby has to be delivered on whichever bed, whichever place you are doing the CPR. So that's something you should know of. That if you're running a CPR code for a pregnant woman and within 5 minutes you've not achieved any ROSC, after 5 minutes, that baby has to come out.
Okay, so in the process of bringing out the baby, won't you still suspend CPR, and that would also
you don't suspend CPR. So you do the CPR, and so there's what we call, so there should be an obstetric resuscitation team where team dynamics are working. They will be so you are doing the CPR and they are delivering the baby.
Okay, that's by cesarean section then.
Yeah, by cesarean section.
Okay. Oh, interesting. Let me ask for that. Any other person with?
Sorry, for this pregnant women, with in that position, how do you now get to do the CPR?
So that's why it requires training. So like Dr. Conteh said, the CPR is actually done left lateral, like tilting, and you will have to find a way of doing the cesarean section. It requires training and practice. And because the reason for the delivery is not necessarily even to save the baby, but to improve maternal outcomes, actually. Because that baby is still there, that pregnancy is still going, reduces the chance of survival of the mother during the CPR. So if after 5 minutes, unless there's a written, but they are against it, but if they are not, after 5 minutes, the team has to find a way of delivering that baby and still doing the CPR. And the emphasis is not on a clean, necessarily CS at the time. It's to improve out survival and later deal with the sequelae.
Wow, very interesting discussion.
The blood loss during the CS, wouldn't it complicate the maternal outcome? I'm just thinking, sorry.
So theoretically, yes. But in terms of the science, the recommendation, so when the AHA are doing these guidelines, they tend to back it with science and data. So per the science and data they have, the recommendation is to go ahead and do it. So it sounds logical that yes, there will be blood loss, and that can increase the risk of poor outcomes. But we're looking at the data, that is the recommendation. Some may even argue that in the context of cardiac arrest, the bleeding may not even be a lot because perfusion already is compromised. But that is more academic and theoretical. But in terms of the recommendation for the data, you have to deliver after 5 minutes.
Impressive again. Any further question?
One question you need to ask yourself is the real. In a cesarean section, how long does it take you to really deliver the baby? So it doesn't take you so much time.
It didn't take you so much. So that's why I say it's not a clean surgery.
Yeah,
just
it doesn't
want
take
to get
so much time.
At least 15 minutes.
15 minutes is even too far. Just to put it in a incision.
You are not dissecting by layer.
Get the baby out.
Get the baby out without injuring the baby. Just go deep enough so that you don't injure the baby
and then
there are get the baby out.
This is irrespective of the pregnancy stage. The moment you're doing a CPR, pregnant woman, that baby is out, whether the baby is alive or not. So you are not really after the baby's life as much as you're after the mother's life. Look good there.
There are machines that can help you do your CPR. Okay. Sometimes you can engage such machines to do your CPR while you continue what you're doing. Well, I came halfway, so I don't know where. Well, maybe I'm not in the best position.
All right.
I'm sure that you have discussed everything in detail, so I'm wondering what I should ask, but I'm sure you will have discussed all the necessary things.
Yeah.
Doctor, you can just ask any question you want to ask. It might throw more light because discussing it again would
Okay, so
enlighten more people.
all right, so just wanted to in CPRO, once you start your resuscitation, there are things you're looking at. First of all, it's a whole lot of organization. So one aspect of the resuscitation team, there must be a leader. I don't know whether you talk about that. It's essential to the outcome, even much more than the technical knowledge. Because if you don't have a leader that leads the resuscitation at that time, everybody can be making us suggestions. So there's one person that leads the resuscitation, which usually may not be necessarily the most senior person, but usually it should be the most senior person who is assumed to have the knowledge. So when you are in a ward or on call, it's assumed that, for instance, senior registrar should be the most senior person to have the knowledge. Consultant is the right to assume like that. So the person should lead the CPRO. So once you lead your CPRO, before you start the shift, really, you should have a brief meeting and everybody should be introduced as the shift starts for the night or the call. Some of these things, sometimes it looks as if they are not attainable, but usually attainable. So everybody knows that A is the leader, B is in charge of airway, C is in charge of defibrillator and scribing, then E is in charge of compression. And sometimes you have someone that even circulate. So this team should be put in place. In hospital where things are working, you may not always come together every evening, but it's already assumed that this is the leader, maybe the SRO, cardiac surgeon, the cardiologist is the leader. Two, you also know that this is the expert in airways, the anesthetists, for instance, to be the expert in airways. Every nurse, as far as even the cleaner, should be ALS satisfied, whether they can do CPR very well, they can shock the patient when necessary. So that's the number one thing. The hierarchy must be defined, because if it's not well defined, once the patient is in cardiac arrest, you see everybody will start talking. And once everybody starts talking, no one is leading. And it's been shown that that is even more of a thing that leads to poor outcome compared to the technical knowledge. Number two, usually once the patient have an arrest, I'm sure we talked about signs of arrest and all the stuff like that. Patient is not responsive. You call the patient, not responsive. There's no signs of breathing. There's no pulse. The CPRO should be started almost immediately. Okay, I just want to start almost immediately. And then you must talk about the idea of the 2 minutes. So did you talk about the 2-minute cycle? So the 2-minute cycle, what do you do? That is very important, because once it depends, the shock you give depends exactly on the patient you are dealing with, whether you are dealing with inpatient or a patient that have an arrest in the ICU. So once you see a patient that have an arrest, usually in the ward, and the nurses are quite experienced, you deliver your first shock. Once, like I heard when you guys were talking about the different orientation to place your pad, usually there are different recommendations, but the one that generally use is to put the pads just lower on the right part of sternum and at the apex, or that's not like the idea is, like you said, to make sure that the apex and the base of the heart is in between the two, because you want to deliver your current. So deliver the first shock, then start CPRO, continue to do CPR. The moment you deliver the shock, don't even bother look at the reading. What I mean is that, of course, initially, once the patient have an arrest, you're going to look at your monitor. Is it shockable reading or not shockable reading? If it's not shockable reading, you follow the pathway. If it's shockable reading, you follow the pathway of shock. Once you deliver the shock, you continue CPR for about 2 minutes. So that's why I said somebody should be in charge of the shock and scribe, looking at the time. And the leader should be giving the command. Once the 2 minutes is almost expiring, at the end of the 2 minutes, you need to do your reading check. You check the reading. You now look at the reading. Is the reading now shockable or not shockable, or the patient have rocks? You need to define that. One of the reasons why you continue to do your CPR, even after delivering the shock, you don't check the reading. So these things are well scripted. Once you deliver the shock to the patient, you don't check the reading, really. You continue to do your CPR, because even if the patient have converted to sinus reading, that initial sinus reading may not be good enough to deliver cardiac output. So you need to assist the cardiac output with your compression for about 2 minutes. That 2 minutes, you check for the reading check. The word is reading check. So when you check the reading check, is it still shockable? Is it sinus? If it's sinus, is there pulse? If there's no pulse and the sinus, that's likely pulseless electrical activity. So you switch over to the other part of the algorithm, which is not shockable reading. Not shockable reading means that you can't give shock. Rather, you want to give your adrenaline, IV, 1 milligram of adrenaline. You give. Once you give, you continue your CPR again for another 2 minutes. At the end of the 2 minutes, you assess. At this 2 minutes now, the leader, you are changing from one person to another in terms of cardiac compression because of tiredness and exhaustion. At this period, as a leader, you are giving instruction to the person in charge of airway, which are usually anesthetists, to secure the airway if it's necessary at that time. At this time, as the leader of the team, you're also looking out for reversible causes. So you are looking out for the T's, for the I's, and then you're looking at the case note, because at this time, the nurses are also giving you the report of the patient background, what's the story, what's the possible etiology. So these are the things the leader does at that time. So you're giving instruction. If you're doing your ABG, right away they do an ABG. You're going to look at the ABG. Is there anything suggests acidosis, metabolic acidosis? Do you need to correct the sodium bicarbonate? This patient is hypothermia. You need to correct. This patient, is he someone that have an MI? Is there segment elevation? Do you need to revascularize immediately? If there's a need, for example, to revascularize the patient because of SC segment elevation, you are moving to the cath lab. If the cath lab is not close by, you are calling the cath lab that's close by. If the cardiology team, if you are the cardiologist, of course, intervene. But if you are taking the call generally for everybody, you're calling the interventional cardiology. So you're doing everything at the same time. And the leader must take charge. If the leader does not take charge, it is going to be a problem, because everything will not be coordinated. In fact, where I am over here, the nurses will fold their hand and be looking at you. Mr. Copy, what do you want me to do? Mr. Godia, should I give their meal their own now? They will call it, Mr. Godia, it is 20 seconds to the end of the 2 minutes. What do you want me to do? So you give the instruction at the end of the 2 minutes, stop CPR momentarily for reading check. They check the reading, their sinus reading. Once the sinus reading, you will tell this one in charge of airway, check if there is pulse, check the carotid pulse, there is pulse. Okay, you can say everybody stay clear. You don't need to check again. Look at it. So it is a well-coordinated, well-scripted, and well-practiced activity, which sometimes, if you've not been involved, it could be a lot of cramming. So these are what are the things I just want to say. So so I don't know whether you discuss some of these things, plus or minus. When do you give your amiodarone? What's the first dose of amiodarone do you give? What second dose do you give? You know, all these stuffs are very important. Okay. I don't know
We
whether
actually
you discuss all that in detail.
You've done brilliantly well, sir. You've given more light to it and another insight to it. He actually touched a couple of almost everything you're saying, but at least saying it again makes it clearer and sticks again. So my side is that any other thing you think we need to know, just say.
So the concept of PNR is very important. I'm sure that's something we don't do back at home. That's the reason why most of our resuscitation is just a futile exercise. Because before, most patients, when they come to the hospital, they need to take an advanced decision that I don't want resuscitation. And you see a lot of patients telling you that they don't want you to resuscitate them. So once you see those kind of patients, once the patient is going to an arrest, the first thing you want to check is, look at the case note. Is there a DNR? Is there DNR means do not attempt CPR? If it's there, we don't bother to attempt. Just do end of care, allow the patient to go very well. Number two, there are some patients that they don't want to even sign such form. But you as a doctor in charge, you have a right to discuss with the patient and take a decision in the best interest of the patient, because there is no use resuscitating someone that have metastatic brain tumor. There is no use trying to resuscitate someone that have metastatic liver disease. There's no use to start CPR, because once you bring the person back, for instance, we bringing the person back from cardiac arrest improve the quality of life and the prognosis? No. So those are the kind of people you have a conversation with them. It's not that you're going to force them, but you're going to discuss with them and all that, and take a decision that there is no need to do CPR in this patient. So once people go into cardiac arrest, you don't bother, because they do that. They've been able to really improve the rate of survival. Unlike back at home, when you want to do CPR for that kind of patient, they will not survive. So that's something that is very important. Number 2 or 3 is the concept of defibrillators. In fact, earlier on this afternoon, they were going around the whole hospital where they were checking all the defibrillators that they are all working. They will on them to make sure they are working. They will on them to make sure they are working. So that it won't be when a patient have an arrest in the clinic, you now remember that there's one defibrillator far away in the office, and then you want to go and bring it. So these are other things again that help to improve the successes of everything you want to do. So I'm sure you must have talked about that when you give the first, second, and when you are planning to give the third shock, you're already telling the nurses as a leader, get amiodarone ready, get amiodarone 300 milligram, adrenaline 1 milligram, get it ready. By the time first, so seconds of 2 minutes, 2 minutes are very important. That's why there's someone in charge of that time. Because at the end of the cardiac arrest and the performance of the cardiac arrest team, they're going to debrief everybody. It's not enough that we've done the cardiac arrest, patient is back. Everybody will sit down and start debriefing everybody. So did we keep to the 2 minute cycle? Did we give the adrenaline, the amiodarone as at when needed? When it was non-shockable rhythm, did you only give adrenaline? Did you give 1, 2, 3 shock if it's a patient in ITU. All this information will be feeded into the national database where audit to be carried out to be sure that everything is followed as planned. So it's a well-coordinated script that everyone follows. And it be sure that once these are properly followed, the outcome of the CPRO is far, far better. And people really come out. I've seen people really come and they do well. So I probably would suggest that if it's possible with any of us, you can enroll for any of the ALS course. I used to think that the cardiologist is not very important, but I don't think that it should be. You have to be certified, really. That's what I would suggest, because those patterns, they help a lot. So let me stop here. Maybe if any question arises, I can to help me to remember a lot. So.
Wow, that's brilliant. That's quite brilliant. I love the fact that because that people have to define their role. That's quite new to me. Yeah. Who is going to be the team leader? I think Conteh mentioned something about training practice, even in the absence of life. You know, we just start call. Who is on call? talk. I'm not even of course. Like this to nobody.
It's a whole lot. Even when there's no defibrillator. Conteh, if I ask you a question for ABG, how do you do ABG over there?
Yes,
Conteh.
yes.
When the patient have an arrest.
So it might be during the cardiac arrest. If you just take, you can do the venous sample and then and do the blood gases on the venous sample.
Fantastic.
Yeah.
Yeah, you can do, because really at that time, what you're looking for, you can show you the electrolyte. So you don't need to go to lab looking for sample in the lab. You can do the ABG by the bedside. I mean, when I say arterial blood gases, you're doing it by every nurse. In fact, as officers, they do. The issues there are many. So as officers does the ABG by the bedside. So you can get the potassium. You can even get the P. Yes. It can give you an idea of the PCO2. The PO2 may not be fantastic because it's VBG. If it's ABG, you can assess the level of oxygenation. So when you see hypoxemia in VBG, you don't want to be bothered too much. Okay, but that can help you to rule out whether the patient is on having metabolic acidosis, whether you need to correct electrolyte derangements, hypokalemia, hyperkalemia. The VBG will also tell you the glucose, hypoglycemia or hyperglycemia, as the case may be. You will see everything immediately. Within seconds, you got your reading and you know what to do with it. So, because CPR resuscitation really involves that we know already. So know exactly what is causing the arrest and able to address it. Because if you don't address it, it'll be shown that that's poor indices of patient able to resuscitate. You know, so that's what.
Thank you, Dr. Kweki.
So usually in the code, the person who is assigned to the IV, once gains access, he takes samples straight away. So for ABG, you do a rapid bedside and blood glucose, really ABG, and then get ready to start administering the medication. Make sure that all the medications are by the side. So once the team lead says give this, then he draws the medication, and then at the appropriate timing, give the medication. one thing I was talking about that I was going to mention was this closed loop communication. I skipped it a bit, but you have what is called a closed loop communication when you are doing a CPR. Okay, so once the team lead gives an instruction, you have to re-echo the instruction. So it says draw 1 milligram of epinephrine. Drawing 1 milligram of epinephrine, and then it says draw 1 milligram of epinephrine and administer after the pulse check. So you're drawing 1 milligram of epinephrine, and then after the pulse check, you administer 1 milligram of epinephrine given. So in a situation, you are in a very tense situation, and the team lead make a mistake. Maybe instead of 1 milligram, you say 10 milligram of epinephrine. So you have to make sure you communicate back. Confirming team lead, you said 10 milligram of epinephrine, and then that will make something click that, oh no, it's 1 milligram. Now drawing 1 milligram of epinephrine. So closed loop communication is very important. Whatever the team lead says, when you agree it, you re-echo it. So it reaffirms it and make sure that the team lead is giving the right instruction. Okay, and if he's giving a wrong instruction, you re-echo. That re-echo instruction, if he has made a mistake, you'll be able to rectify and then change the instruction. So that closed loop communication is very important.
Wow, that's excellent. Wow. Can we give the option to any other person that want to ask questions so that we can clarify if you have any concerns?
Thank you, Dr. Conteh. Thank you, Dr. Conteh. Please, I'll need a clarification on the dosing for VT. I sometimes come across where they talk about giving a dose of amiodarone at 150 milligram first in the first 10 minutes, and then continue with 1 milligram per kg. So 1 milligram per minute, which usually over 6 hours, usually equates to 360 milligrams. But in some other places, you will see 300 milligram and then continue with 150. So please, what is the actual right dose to go with?
For ACLS, the first dose of amiodarone is 300 over the 10 minutes, and then you give 150. And then after the 150, it's an infusion. Okay, so 150 is the second dose. It's here. Okay. So the amiodarone, the first dose is 300. Okay, the second dose is 150. Okay.
Okay.
And then after the 150, then you do the infusion at 1 milligram per kilo.
So is there any place at all for this one I'm talking about, 150, then 360?
Hello.
I don't know if you ever come across. Okay, yes, I can hear you.
Dr. Conteh.
Yes.
Yeah, so can I come in?
Yes. Why?
So first of all, you need to determine the indication for the antiarrhythmic you're giving. Are you giving it in the context of cardiac arrest, or you are giving the context of a stable tachyarrhythmia? Now, if you are giving it in the context of a stable tachyarrhythmia, amiodarone is recommended for wide complex tachycardia. So let's say you have a patient with a wide complex tachycardia, which is stable. And because of that, you are not synchronizing, you are not doing cardioversion, and you want to use an antiarrhythmic. In that sense, your first dose is the 150. You understand? And if the person cardioverts, then you maintain the person on 1 milligram per minute for 6 hours, then 0.5 milligram per minute for the next 18 hours, which will become a total of averaging 900 milligram in 24 hours.
Okay.
But if you are giving it for cardiac arrest, then the first dose is 300.
Okay.
So it's the setting that defines the initial dose.
Okay. Still over 10 minutes.
Yes. In fact, in cardiac arrest, push and go, because it's the person that's in cardiac arrest. So in cardiac arrest, the medications are push and go. And you flash, you push, you go, you flash, you push, you go, you flash.
Okay. Thank you.
All right, that's
preferably if most of these patients, if they're already in ICU, they already have the central vein. If this cardiac arrest happen in patients that are in ICU, they have central vein. You can give free central vein, but if they happen in the world, or you don't have central vein, you can use your peripheral vein. That's fine. So to give, as he just said, okay. But the point here is that these activity must be well coordinated. If it's not well coordinated, usually make everything very wrong. I think that's the reason why they do the briefing after everything, to be sure that everything is well followed. Okay, thank you.
Dr. Jacqueline, are you clear?
Yes, I am. Thank you very much.
Dr. Florence, you wanted to say something?
No, okay. I wanted to ask a question about the cardiac arrest using amiodarone. Must we give the second dose of 150 milligrams?
All right. Dr.
So you
Conteh.
go according to the algorithm. If after the first dose of the amiodarone, the patient gets a pulse and the cardiovert to a sinus rhythm, then you go to the maintenance dose straight away, 1 milligrams per kilo. But if they still continue in VT or VF, then at the 4 minutes from the time you give the initial dose, you have to give the 150 milligrams.
That's fine. Dr. Florence, you clear?
And if he's not responding to amiodarone after you have given the 150 milligram, what would you do?
So after you give the 150, then you have to, you are doing your secondary assessment as well, doing your HRTs. So and also you are looking at the rhythm as well. So if you are seeing a polymorphic VT, likely to be a torsade, then you want to bring in magnesium sulfate, which will help to control that one. So you have to continue assessing the patient.
So this patient now, this is the fourth, at the third cycle.
Yes.
You have given adrenaline, you are giving amiodarone 300 milligrams. Yes. Then you started the fourth cycle, and it's still possibly ventricular tachycardia. And that's the fourth cycle now. You're giving the 150 milligrams of amiodarone.
Yes.
Now, you check at the end of the fourth cycle, it's still probably now in ventricular tachycardia, fibrillation. Now you're entering the fifth cycle. You have exhausted all the opportunity of your amiodarone, and now you have also given it's not too sad, so magnesium is not in view. So what options do you want to consider?
Lidocaine is there.
Yeah, second line. That's the point I'm really pushing for. Because you want to start moving to second line. Lidocaine is like a second line. It's not the first line. Amiodarone is the first line. Yeah. But lidocaine, in fact, I had such an experience where we have given everything, amiodarone, done everything, and patient is still running VT to VF here and there, deliver several shock. Then we moved to lidocaine. Because after we gave lidocaine, deliver a shock, that the patient returned to us. We later realized that the patient had bypass surgery recently, and when we started, the patient had gained normal activities. We did an echo. We found out that the patient had rupture myocardium, whether from the shock, CPR, or from the surgery. Very quite sure, but she had pericardial effusion, blood, hemoperitoneum, obviously. So they had to take the patient back to the cardiac surgery and open up the patient and all the logistics. So sometimes it could not be straightforward. Sometimes after the first shock, patient could just return to normal spontaneous respiration, rocks, and you're happy, everybody's happy, and continue your maintenance dose of amiodarone. Of course, you don't forget to address the etiology. Number two, you don't forget to speak to the teams that are involved, because you may need to now speak to the cardiologist, you may need to now speak to the interventional cardiologist, You may need to now speak to what was it called now? These people, interventional respiratory physician. You may need to speak to the cardiothoracic surgeon. So it's not enough that the patient has regained and you're walking away. So you need to speak to people that you need to hand over the patient to. But if you're the cardiology and interventional cardiology and you need to take decision, you take a decision. But if you're not, you need to escalate to the next person. Patient doesn't just gain rocks and then, oh, we're happy, walk away. No, you need to address what will be responsible. Of course, give your maintenance later on. So it could just be the first shock. Sometimes it doesn't happen like that, and we must have an idea to move to one to another. Like he has said, sometimes magnesium could be a very saving grace. Some very recalcitrant arrhythmias. Once you just give magnesium, it seems to solve a whole lot of problem with all these people with arrhythmia not responding to the usual medication. Even fast atrial fibrillation, when you have used all your options, sometimes magnesium will help. All right, thank you so much.
All right, that's quite brilliant again. Thank you. Is there any other person? We are almost come to the time of our closure. Any person with further clarification? Ayodeji Stephen, you wanted to say something? Ayodeji.
Hello. Okay, Ayodeji.
Yeah. No, I don't have any question. Sorry, it was a mistake.
Okay, all right. So let's.
So don't forget also to discuss with patient relatives because they will be there waiting to hear what has happened. Especially as the leader of the team, you may need to have a chat with the relative, explain everything to them, what happened.
Okay.
The emergency, the short-term care, the long-term care, and the prognosis of what will happen in the long term. So all these things need to be clearly stated. The plan you need to do thereafter and to address the problem correctly.
So at what point will you give marks now?
You marks of magnesium?
Yes, sir.
So first of all, once is to start, like you said, once you check and you just see to start, the treatment is magnesium sulfate. That's one indication. Number two, you have exhausted first line, second line. First of all, you must know that any resuscitation have lasted more than 5 minutes, patient is likely not to regain consciousness. So that's the reason why someone was talking about the pregnant woman. Once you lasted for 5 minutes, you need to deliver the baby. Because any resuscitation have lasted more than 5 minutes, the prolonged duration more than 5 minutes is an indication for poor outcome. So, but if you look at the time which you give, first two, the longer it is, more than 5 minutes, the tendency for you to outcome, is poor. So once you're giving your first, you give a Mediteron, give lidocaine, magnesium, you start thinking of magnesium sulfate to give. In some of these are when expert opinion come into the issue. In fact, the case we had here, I've given one case I've given 1, 2, 3, then we'll move into magnesium. A lot of the ICU guys were shouting, da, 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 da. But we gave it anyway, and then the patient recover. So after you've exhausted the option of lidocaine, so you want to move into that direction. But once the patient,
Just so that you can just follow up with this answer to me, please. So what, in terms of timing, when do we stop resuscitation? Since beyond 5 minutes, the outcome is poor. And if the patient still, could we use timing to stop resuscitation?
There are many indications for stopping resuscitation. First of all, is a decision of the leader when to stop. 2, you can't use timing alone. Okay. But what I'm just trying to say is that the longer it is, the poorer the prognosis that the patient is going to make it out of it. Most time, patients tend to recover because you have selected the patient you are trying to resuscitate anyway. But once you prolong the resuscitation, the team are tired, the patient have an obvious pathology that cannot be corrected immediately. Then you see a patient coming, gaining rocks, and again having frequent cardiac arrest. So these are some of the reasons when you want to stop. So timing is not the only reason. I'm just trying to say that the longer your resuscitation, once it's getting more than 5 minutes, a study that be done is that chances the outcome is poor outcome is higher. So the duration is not the only reason to stop.
So does it mean that okay, you're giving first cycle, second cycle, third cycle, the patient is not recovering, you can continue ad infinitum?
Which of the so what you say, which of them now? What are you adding? Is it the amiodarone? Is it the lidocaine? Is it the
You've given epinephrine, you use your odd number, even number epinephrine, you gave your abnormal, you went to lidocaine, and can you still continue if there's need for?
So that's why so this kind of thing is individualized. You can't leave a straight blanket that's 1, 2, 3, then stop. So there are some patients you see, you continue to shock the patient when you can remember that you can increase your voltage, your energy. Okay, so you can incremental increase of your energy. So if maybe 150, 200 I started with is not working, you can increase incrementally to 50 like that. So once you keep increasing your current, okay, that will also improve the recovery of circulation. But decision to stop really is also based on the patient and based on the leaders to assess the patient. Once you've assessed, you've kept shocking, nothing is happening, kept shocking, delivering a shock, and patient is still not responding. After some time, you are going to say now, then you already assessing some signs that the patient is having poor cerebral function, the eyes are, things like that. Okay. You're going to stop after some time,
Okay. Dr. Dr. Conteh, you spoke about core temperature of 32 to 36 degrees Celsius. If the patient is hypothermic, you want the patient with a warm saline, because I thought you only mentioned about bringing the temperature back. So what would you do?
Sorry, are you talking to me? I didn't hear that.
Okay, it was Dr. Conteh about the core temperature of 32 to 36. What about if the patient is hypothermic? I don't think it's there.
Hello. If Dr. Conteh is still not on, it's on, but I think probably it's having issues with the network. So the essence of the targeted temperature management is to preserve neurological function as much as possible. So you have achieved ROSC, patient is out of cardiac arrest, but you're looking at preserving neurological function because, as it was said earlier, CPR beyond 5 minutes, in fact, the evidence says 4 to 6 minutes, you may have an opportunity, but beyond that, you have significant neurological damage. So you want to minimize the damage, and that's the evidence for targeted temperature management. So if your person at the time of ROSC, the temperature is less than 32, then you can infuse warm fluids to increase the core temperature to that range, 32 to 36. You can cover with blankets, put off the AC. You can do practical things. If the person is also too warm or hot above the target 32, 36, then you can use the ice and cold fluids too, because the evidence is that if you keep the core temperature within that period, that range, you help minimize the risk of neurological damage. In fact, in post-cardiac arrest, the patient is supposed to have a CT scan and EEG within 24 hours. There are things that we are supposed to do, but most of the times we are unable to do these things. But at least for targeted temperature management, for those who are unable to follow commands, but if the person is able to follow commands, TTM is not recommended. So essentially, that is the basis for targeted temperature management.
All right, that's brilliant. Thank you again. Prof wanted to say something. Hello, Prof. Hello, Prof. Vladimir, sir.
No, I'm not saying anything. No. I just came in. I just joined. I just joined. Sorry.
I saw your mic unmuted, so I thought probably you wanted to say something. Okay. Dr. Paki,
yeah, maybe, when he talked about 32 degree, I'm sure probably that's what caught your attention. Why would you want to maintain between 32 and 37? Did that not also hypothermia? So sometimes when you are in a very cold environment, people can be as cold as that 32 is good for their bodies. I wanted about as at 2, was it last week also? It was announced over here that there's going to be heat wave everywhere. And guess the heat wave 22 degrees. That's the heat wave. So you can imagine 22 degrees. Seriously, 22, 23, 24. That's the heat wave that they are talking about. So
they should come and get 40 here.
You can imagine. Right now, here is our minimum AC is 18. That AC that we use in the house, 18 and 16. 18, right? 18 minimum. It's 18.
No, it's 16.
16. Okay, minimum is 16. So that's what you get here. Here now it's about 17. Temperature is we have gradually started to come down recently. It's moving towards winter. So that's the point. So just raising the core temperature to 32, 37 is able to warm them and provide and maintain vital organs. So, and these things, sometimes they look very practicable, but they're very easy to practice because they're just there. I've seen, this will be done. In fact, the ambulance driver, the paramedics, they would do it before they get to the emergency. So they're very easy to do. Just put a warmer. Because these things are all scripts, they're all guidelines, they're properly scripted, and everybody pick up the script. You can just do anything that should be done as long as you can read and follow instruction. So they're not really difficult. They're not hard, because everything can be properly. You can do the warmer is just there. You just warm. If you need to put warm diffusion, just then. Temperature is you're seeing everything, you're following them up. So the concept, that's why I talked about the concept of reversible causes is very important. You must look at the cause of the cardiac arrest and treat it. Because if you don't treat it, the patient is going to have another one, and another one, it's more serious than the previous one. Thank you.
Wow, thank you again for clarifying. Thank you, Dr. Eugene. Thank you, everyone, for making this discussion quite very robust. Thank you, Dr. Conteh, for an excellent presentation. Thank you so much. In the absence of any other clarification,
before you go, I'll put you. Sorry, before you go, yes, I know that discussion has been very intense, and probably forgive me, Prof, that presence have not been very massive. A lot that are in my hand. I'm sure Prof is also quite up. I had a discussion with you recently, and I'm sure he should, if he's here,